Bone and Joint Clinic / UT Physicians. Her primary practice location is in Sugar Land. I do want to say that you can read her bio in there and all those great things, but I do want to emphasize she was a collegiate golfer at Princeton, and I understand it's like a pretty neat college to go to. And but one thing I do want to remind everyone of, and this is from me personally, she does a lot for sports medicine. She really gets what we do. She really is very open to everything that we do as athletic trainers and therapists. She's helped us with physicals. She's been on with a sign-off doctor for athletic physicals for us. She's also done sideline coverage. And to that, you guys understand the relationship you have there during a game with the physician being there and really taking a lot of load off you. So it's for that, we're very grateful. But she's spoken before at the update, back when we were at Minute Maid. She's been gracious to give of her time. We asked her to focus on what the title is. And for some of us, especially as more seasoned veterans, you know, the wrist is pretty complicated. You know, the kid comes in, there's something wrong, you're not sure what you're doing. You poke it, it hurts, let's ice it. Well, I can tell you that this type of talk I think was needed, which is why we asked her to give it to. So she is the proud mother of 2 children, recently had a 2-month-old, correct? Yes, so she's here, she's still sane, she's all good to go. And without further ado, Dr. Candice Teunis.
Thanks. Well, good afternoon. I'm really honored to be asked back again after a couple times speaking on a few different topics. Before, I've done some stuff about basic injuries and scaphoid fractures and things like that. So this talk, ulnar-sided wrist pain, is just a tough thing for me to evaluate. And I think, you know, when somebody comes into, you know, your office and they say my wrist hurts, and it's kind of a little overwhelming sometimes. So this is kind of a diagnostic talk a little bit, just to kind of, you know, give you some tips on the anatomy, some of the more common, you know, diagnoses and things like that that might be giving you pain on the ulnar or pinky side of the wrist. So I have no financial disclosures to make. So, you know, pain along the ulnar side of the wrist is a fairly common complaint. It affects people of all ages, from your teenage athlete to, you know, 6-year-old grandfather, and it has a lot of different causes. It's very multifactorial, and I kind of liken it to sort of the low back pain of hand surgery, because it's kind of complicated and it has a lot of different things to sort of be aware of when you're trying to make a diagnosis. It's not advancing. There it goes. So the goal of this talk is, again, to help you. If somebody, you know, a kid comes in and says, my wrist hurts. And one of the things that I'll do, because sometimes I'll just kind of say, oh, it just hurts here. And so one of the first things I do is kind of say, draw a line down your wrist. Does it hurt on the pinky side of your wrist or the thumb side of your wrist? Because the differential is totally different between the two. So this is geared towards the sort of the pinky or ulnar-sided aspect of the wrist. And we'll go through some of the anatomy, some of the causes, and some of the treatment options as well. Next. So for the bone and the joints and that are a factor over here, you know, you have the ulnocarpal joint here. And this is obviously what contains the TFCC. You have the lunate, the triquetrum, the hamate. Sometimes you can also have, you know, injuries here at the base of the 4th and 5th metacarpals, and then also the distal radial ulnar joint, or the DRUJ, down here. And all these bones and joints can come into play. Likewise, there are ligaments that connect these bones. You know, you have the intrinsic ligaments of the wrist, which are basically the ligaments that connect all of the small carpal bones. Then you have the extrinsic ligaments, which are the more superficial ligaments that kind of go across the back or the dorsum of the wrist. And these are commonly injured in a sprain, and they kind of come to a point and insert here on the triquetrum. So again, you have the, you know, one important ligament here between the lunate and the triquetrum, and then again the extrinsic ligament, which sort of sit on the back and insert on the very dorsal aspect of the triquetrum. And then we'll look at the TFCC, which again is located in here in a little more detail. Yeah, it's not advancing well, sorry. So for the tendons, the two really relevant ones are going to be your ECU, or your extensor carpi ulnaris, and then also FCU. ECU sits here in a groove at the end of the distal ulna. FCU is again on the sort of more volar or flexor surface. Both of those can be involved in tendinitis, and we'll talk a little bit more about that later. And then the neurovascular anatomy, the ulnar nerve comes around the inside of your elbow where it can be compressed here. It travels down the ulnar aspect deep in the forearm and then into the hand. Before it comes into the hand, it sends a branch off here, a sensory branch that gives you sensation to the back of the hand. So this is sort of all told the cutaneous innervation of the hand, which is basically the pinky finger and one half of the ring finger typically. And then your ulnar artery travels along with the nerve, again, to anastomose with the radial artery and give you the blood flow to the hand. But the ulnar artery is predominantly responsible for giving you blood flow to, again, the ulnar aspect of the hand. So when I'm taking a history with one of these patients, the first thing is, was there any trauma? Because you'll have traumatic causes for ulnar wrist pain, and then you'll have sort of more insidious or gradual onset. And if there was trauma, what kind of trauma? Did they fall on it? Or was it some kind of injury involving a bat or a golf club? Because those can help point you into a different direction. Or did it develop gradually? Is there certain aggravating sports? Racket sports are common for causing ulnar-sided wrist pain. Do they have any associated neurologic symptoms, any numbness or tingling? And then also, is there anything where they're doing a lot of prolonged pressure? In particular, cyclists will be prone to certain types of issues in the ulnar wrist and hand. So when I'm examining it, the biggest thing that I can sort of tell you is to sort of be very specific in your exam, in particular when you're palpating different areas, and we'll look at that in a second. But so, first kind of palpate different areas and see, which is most tender. Is this it, or is this it? And then assess their range of motion. Is it painful? Flexion, extension, as well as pronation and supination. And then strength testing, does that reproduce any of their pain? And then a good vascular exam, a good nerve exam, and then specific ligament tests, as well as specific tests to look at the TFCC, and then also to look for ECU subluxation. And that's kind of the general overview. We'll go into a little more detail. Drive me nuts. So for the surface anatomy, this is a kind of marked out here, some good surface anatomy. These are actually also the wrist scope portals that we use. But basically, this tells you kind of where the edge of the ulna is, where the triquetrum is, these different bony landmarks that are quite helpful when you're trying to figure out what is the pain generator. Here you can see this is the pisiform, and it's right there at the base of the heel of your hand along the ulnar aspect, right at your wrist flexion crease, and it is contained within the FCU tendon. And then the fovea is that soft spot. If you come out the end of the distal ulna, you'll kind of dip into a soft spot, and that's right where the TFCC is. And then if you go farther out along the hypothenar eminence of the ulnar aspect of the palm, you can feel the hook of the hamate, which also can be injured. So in looking at range of motion, you look at flexion, extension. You want to test resist ECU, resist ulnar wrist extension and ulnar deviation to see if that really reproduces the pain. Also ulnar deviation just passively. And then when you're looking at pronation and supination, observe the end of the ulna. Does it look a little bit more prominent in certain positions? Because that can give you a hint as to some instability of the distal radial ulnar joint. So for a vascular exam, you can just palpate the radial and ulnar artery pulses, but you can also do an Allen's test where you have the patient clench their fist and you occlude both arteries. Then you can have them open and relax their hand and let one artery free, and you can see if that artery fills well. Specifically, you're looking at the ulnar artery when you're looking at ulnar wrist pain. You can also palpate the artery runs right next to the hook of the hamate, so you can kind of feel in there. Does it feel like there's a mass or anything like that, or just some fullness? Ulnar nerve exam is important to do when you're looking at ulnar wrist pain. You want to look for any signs of cubital tunnel syndrome. An elbow flexion test where you hold the elbow flexed for a period of time. Does that reproduce any of their pain, any numbness, tingling? The ulnar nerve then travels down here through Guillen's canal, and you can also sort of see if it's sensitive by doing a Tunnel's test or tapping along the nerve. Do they have any tingling here? And you test for the strength and finger abduction. If you spread your fingers out, that's predominantly what the ulnar nerve does in the hand. And then specific ligament test for the if they've had an injury to those extrinsic ligaments that we talked about, the superficial ones that insert here on the triquetrum, they'll be fairly point tender there. For the lunato-triquetral ligament, you can actually shuck in and grab the lunate and the triquetrum and try to test for any instability or pain between the two. And then in assessing the distal radial ulnar joint, you put your hand on one sort of hand on the distal ulna and then one on the distal radius and shuck between the two, see if there's any more instability compared with the other side. Now, going into the TFCC, I think this is I think where the meat of what y'all would be seeing. We abbreviate it for triangular fibrocartilage complex. It's a fairly complicated series of ligaments and other structures that exist on the ulnar aspect of the joint. So there are ligamentous structures that help connect the ulna to the carpus, and then there's ligaments between the distal radius and the ulna. And then there's also kind of a disc in the center. So I always describe it to patients. It's almost like the meniscus in the wrist, and it looks kind of like that also when you're scoping it. And it's like you combine the meniscus and the lateral collateral ligament of the knee, and you put it in the wrist, and that's essentially what the TFCC is. It helps to support the distal radial ulnar joint. So if it's damaged, you can get instability here. So TFCC tears are grouped into basically two sections. You either have traumatic tears, which happen after some sort of injury, or degenerative causes. And they're classified, and it's not really, it's up here, but it's not super important, but they're basically classified based on the location of the tear. So these injuries will usually happen from some sort of acute rotational injury to the forearm or a combined kind of axial load injury with maybe some distraction along the ulnar wrist. It's kind of like the wrist sprain that just is not getting any better. So I see it in gymnasts, racket sports, and then also if you're using a drill and it binds up and you get that kind of twisting moment, that's a very common way that you can injure the TFCC. You can have it associated with distal radius fractures, and they can also complain of symptoms of DRUJ instability, some clicking or popping when they go to twist or rotate the wrist as well. So in assessing for TFCC injuries, you want to look, they'll have tenderness in that fovea, that soft spot there on the ulnar aspect of the wrist. They'll have pain with compression. So if you ulnar deviate the wrist, they'll have pain with that. If you place the wrist in ulnar deviation, compression, extension, that will really kind of elicit pain of the TFCC. And then also they'll sometimes complain of pain with weight bearing. When they go to get out of a chair, it'll bother them. And the biggest thing in assessing these, and the most important thing for TFCC injuries is the DRUJ unstable? Because that's crucial as far as treatment's concerned. So here's just some diagrams of some exam findings here. Tenderness right there at the fovea. Here's what an ulnar carpal compression test looks like, where the wrist is in ulnar deviation, and you can kind of rotate it through extension, and it'll get pain here. And then DRUJ instability. You see here, see how the distal ulna is a little bit more proud. Now everybody looks a little bit different. Some people have a more prominent distal ulna than others, but and so that's why you compare it to the other side. And in different positions of rotation, see it's almost kind of disappeared here, where it's more prominent there. And again, the piano key test we talked about. So these all get x-rays, and you can look for wideness. See, here's the DRUJ is a bit wide, the distal ulna is a bit dorsal. And again, here, the very, very prominent distal ulna here. And if there's any question, because these all can kind of, people can look different on this lateral x-ray. So you always want to, if there's any question, I always compare it to the other side. Most of these will get an MRI. Here's an MRI of a normal looking TFCC. See this nice smooth black ligament here attaching to the ulnar styloid, versus here's a TFCC tear where you have this dark ligament and then really nothing here. It's no longer attaching there at the base of the ulnar styloid. Usually there's contrast that's placed into the joint for these, and you can see contrast kind of tracking proximal into the DRUJ. So just because the TSCC is torn does not necessarily mean that they need surgery to fix it. It really depends on DRUJ instability. So if the DRUJ is unstable and they have a TSCC tear, bottom line, they need it repaired. Otherwise, they can be splinted, rested, and it can take, 6 to 8 weeks for these to kind of settle down. Sometimes I'll offer injection to see if that helps kind of speed the sort of pain to resolve. But then, in high-level athletes, there is some argument for early repair just so that they don't have to wait the trial period of splinting and resting. So usually these are repaired with scope. And sometimes they're just, kind of cleaned up. It really depends, again, on the location of the tear as far as what you're able to do. So sometimes with these little central tears here, they're just kind of cleaned up and they go into a splint and they can return to activity pretty quickly within about 6 weeks. But if you're going to do a repair, like as shown here, where you're passing stitches through to repair the ligament, sometimes the DRUJ will need to be pinned. These folks oftentimes are going to go into a long arm cast to control for rotation and won't really start range of motion before about 6 weeks and probably aren't back to full activity until closer to about 3 months. So there's a lot of variation as far as, if it's repaired, the rehab will be much longer. So ulnocarpal impaction is kind of like the degenerative cause of TSCC tears. And these folks, they have a long distal ulna where the distal ulna is longer than the radius, and it essentially abuts into the carpus and puts more pressure here through the TSCC, so you can get degenerative tears there. Here you can see some changes in the lunate where it's got some cystic change. It's kind of like early arthritis on this aspect of the joint. And these are treated with, if they fail conservative treatment, can be treated with an ulnar shortening. Now, the LT ligament is a fairly uncommon ligament to tear in isolation, but this is actually one of my patients. It's the connection between the lunate and the triquetrum. As we talked about, you can assess it by doing a shear test where you sort of see for any reproduction of their pain in motion between the lunate and the triquetrum. Most often it kind of heals on its own if you put them in a wrist splint and modify their activity for about 6 weeks. It usually kind of settles down on its own, but every once in a while it will tend to remain painful. And in this case, here's a scope picture, here's the lunate, and here's the triquetrum, and all this frayed stuff is a ligament tear. And this is looking from the other side of the joint. There's a big gap here and a big step off. There's the edge of one bone, here's the edge of the other. So there was a lot of instability here. Basically, I just cleaned up the ligament and then pinned it, and he ended up doing fine. But that's about the only time I've ever seen an LT ligament require surgery. So other trauma that can cause pain on the ulnar aspect of the hand or the wrist, hook and hamate fractures. These are classically, if you golfers, you hit it fat and the club bangs into the hamate, which is prominent here. You can fracture here. I've also, baseball players will get this injury, and they'll be focally tender right over the hook of the hamate, and oftentimes they'll need a CT to diagnose it, but there's the fracture right there. These are treated with just taking the hook out and can return to activity pretty quickly. Again, this sort of quote unquote wrist sprain is an injury to these extrinsic ligaments. Sometimes you can pull off a little fleck of bone. Here's a triquetral avulsion fracture here. Those will, just treated kind of symptomatically with a wrist splint as needed. And then you can also get fractures near the 4th and 5th CMC joints. So ECU, the extensor carpi ulnaris can get tendinitis in it. It can also subluxate. These will kind of be a little more insidious onset. Although the folks that subluxate, that can actually happen fairly acutely. For ECU tendinitis, here's a diagram, or here's an MRI picture. You see all this, here's the ECU sitting in its groove, so this little groove in the distal ulna, and there's fluid around it, fluid within the tendon. These that can be specific to, I see this a lot in racket sports, or tennis players and whatnot, where they can get tendinitis, and oftentimes treated with just splinting. Therapy can have a big role for this, as well as injection. For ECU to subluxate, so here's ECU, and with different positions of forearm rotation, ECU can pop out of place. So here, as you bring it into supination, that's when it's most apt to kind of fall out of place. And here you can see there's the groove, and then the ECU tendon is kind of sitting off to the side. And so if you put your finger over ECU, and when you rotate, it should stay in its groove. And folks where it's subluxated will tend to pop out. here's an MRI picture of ECU not in its groove. So here's where it's well located but has tendonitis, and here this person has kind of a shallower groove and the tendon is sitting outside. Dynamic ultrasound can also be helpful to diagnose it. Here's an ultrasound picture of ECU within its groove, and then here it's kind of rolled out to the side. So again, so for treatment, here's the ECU tendon sheath. These folks can get pain that radiates kind of all the way up the forearm. And again, rest, immobilization, sometimes an injection. For those that come in with a popping and have a subluxating ECU, if you catch them early, sometimes you can treat them in a long arm cast with the wrist actually in pronation, which helps pull the tendon into the groove. But I haven't overall found that super successful. So usually if they come in to see me, they're usually getting a reconstruction of their sheath. Where here's ECU tendon, that sheath has been opened. I usually use a burr to deepen the groove so it can sit a little bit deeper in the groove, and then put suture anchors to help tighten up the sheath so it can stay in place. So DRUJ instability, again, is something that usually goes along with the TFCC injury. This is not subtle. This is in association with a distal third radial shaft fracture. This is a Galeazzi injury. And so this is not subtle DRUJ instability, but sometimes DRUJ instability can be a little bit sort of more subtle than that, and you have to distinguish between, is it the distal ulna that's kind of popping in and out, or is it ECU that's falling in and out of its groove? And sometimes that can be hard. But if there's any question, again, it's always helpful to compare it to the other side. Now, if you catch a TFCC injury early and it's repaired, then that can manage the DRUJ instability fairly well. But sometimes they'll come into me late, and the surgery for that's a little bit more complicated. It requires a ligament reconstruction, and their rehab is quite a bit longer. It takes probably 6 months for them to be back to full activity after that. And if you don't treat DRUJ instability, the distal ulna should sit right nicely in this groove here, the distal radius. If you don't treat the instability, then you can get arthritis here long term. So a couple kind of less common causes for ulnar, wrist, and hand pain. Hypothenar hammer syndrome. This is an injury to the ulnar artery, which either causes it to occlude or block off, or you can get an aneurysm where you can also have disrupted flow. This happens from single or repeated blows to the heel of the hand. So if you're using like the heel of your hand as a hammer to bang something in, this is what can happen. You can also see it in golfers, mountain bikers, and they can present with symptoms of ischemia or coolness to the fingertips, particularly the pinky and the ring finger, or cold intolerance. And they can also get some ulnar nerve symptoms, as well as just pain along the ulnar aspect of the hand, or the hypothenar aspect of the hand. Diagnosis is made through angiography. So here's a nice angiogram showing, here's the ulnar artery, and you see this big blob right here. That's the aneurysm. Sometimes, with just some rest and some antihypertensive medicines, you can treat these, but oftentimes if the pain or especially ischemias persist, they need surgery, and you have to resect. Here's an aneurysm that's been resected. It's got all this clot in here. There's the ulnar artery, and then it's treated with a vein graft. And then the other thing to be aware of with ulnar wrist pain is you have to examine the ulnar nerve, because I've seen people who have come in, they've had previous surgeries for either TFCC problem, DRUJ problems, and really it was an ulnar nerve issue that was giving them ulnar wrist pain. The ulnar nerve can cause some very vague symptoms of just pain. It's not always numbness and tingling, so the ulnar nerve always needs to be examined if somebody comes in complaining of ulnar wrist and hand pain. Classically, they'll have numbness and tingling, sometimes weakness. The ulnar nerve can be compressed in basically two different areas. One is the ulnar tunnel, which refers to basically the ulnar nerve through the hand. It comes through here and wraps around the hook of the hamate and can get compressed in different zones in here. Typically, we talked about the dorsal branch is already exited before the hand. So usually the sensation on the back of the hand is preserved, but they can have numbness and tingling in the ring and small fingers. Sometimes this can happen because of a cyst that can occur near these bones. And so I usually MRI these to look for anything that might be causing mechanical compression. And if it doesn't improve with splinting, it can require decompression. So most commonly, though, as opposed to in the hand, the ulnar nerve is usually involved at the elbow, and it travels around the medial epicondyle. It's your funny bone nerve, and it's very vulnerable to compression here. Usually, they'll have some component of elbow or forearm pain, but not always. Sometimes there's just this vague sort of discomfort along the ulnar forearm and wrist. Conservative treatment for this is to avoid positions that keep your elbow bent for long periods of time, or avoid pressure on the inside of the elbow. I have a mild case of this, and when I was driving a lot between here and San Antonio, and I'd rest my arm on the center console, my hand would go numb. So things like that you just avoid, and it can be managed typically very well with that, but in some cases it can't, and in which case it can be decompressed and sometimes transposed to relieve the pressure on it. So just to summarize, again, ulnar wrist pain is very multifactorial. As we've seen, you can have ligament injuries, you can have nerve issues that can cause pain. But questions to ask, obviously, is there trauma? What kind of trauma? Are there specific activities that elicit the pain? Did it come on gradually? And when you're examining the wrist, be very specific. Sometimes what I'll do if I'm narrowing it down, and I'll say, okay, well, is it number 1 or number 2? Is it tender over the tendon, or is it tender over the fovea? And sometimes it's hard, and sometimes you can get it narrowed down, but you're not totally confident as to which it is. And I'll use injections sometimes to really help figure it out, because it is a complicated issue. Important to ask about any neurovascular symptoms, and then also to assess for any instability symptoms, especially when you're looking at TFCC injuries and in regards to the distal radial ulnar joint. Thank you. I'm happy to entertain questions. Yeah. Sorry about this. This is kind of funny. It doesn't really want to work that well. So I change it.
I do have a question about referring on for therapy.
Yeah.
Would you feel comfortable releasing, say, a football player,
yeah,
to someone in our charge and try to?
Let me step away so it doesn't.
My question was, would she feel comfortable releasing a post-surgical patient to an athletic trainer? Are you more comfortable going to a therapist? Or what's your
so if for like TFCC repairs, yeah. So I think it depends. I think for an acute tear, I think it's probably fine to go straight to an athletic trainer. I usually will cast those again, depending on the degree of DRUJ instability. If they were a basic little central tear that I just cleaned up and put into a wrist splint, I think they can pretty quickly go back to trainers and get gradual resumption of their range of motion. If they had a very unstable DRUJ that was pinned, I might send them at least to start with a hand therapist so they can gently work on rotation. For the folks where I've treated chronic DRUJ instability with a ligament reconstruction and tendon grafts, those have to go to a therapist, because the tendency is to want to really regain the rotation quickly, but you can loosen up the reconstruction too quickly. So I think if the more unstable the DRUJ was, then they might, at least initially, just because need to be kind of, therapy needs to be at a slower pace. And so I might start with a fairly specific guided therapy with hand therapy and then transition. Does that answer your question? Anybody else? Nothing. Silence. The first lecture after lunch. It's tough.
All right, Dr. Teunis, thank you very much.
Oh, you're welcome.
And he is based out of Memorial City as one of his offices at Memorial Hermann. And then he's also in the Sugar Land area, but he's here to talk to y'all today about the cardiac issues with the adolescent. Also for him, if y'all need him to, he has agreed to If you need him to come talk to any of your board members, administration, or any of that regarding ECG testing or any of those things, he said he will be more than happy to. So if you can contact me, I can get you in contact with him for any of that also.
Get this microphone working. Okay. Well, thank you for coming out. I am, again, pediatric cardiologist Steve Lorch. As I'm sure all of you guys have come up, have questions about the cardiac examination and the recommendations. There goes the microphone. The recommendations that the governing bodies of the state of Texas or the UIL or whatever alphabetical organization you'd like to belong to have. So hopefully I'll be able to get rid of some of your misconceptions and help you to talk to the parents and the kids about what is going on, why they have to fill out this, is it up to 6 pages now? Last time I think it was 4 pages, front, back, trifold, 6, 8, 10 page form and all these check boxes. There we go. So the all-important, I have no financial interest to disclose. So at the end of this presentation, you should be able to consider changes in your practice, related to the use of the current guidelines from the American College of Cardiology, whom I listen to, ordering of or recommending of specific diagnostic tests, elimination of the outdated diagnostic testing methods, and prescription or recommendations for newer different therapies. Also, have some competence and being comfortable in counseling families and patients. So unfortunately, the most recent guidelines, as you see, are from 2007. These things take forever to get released, and they take forever for people to come back with. So the most current recommendations endorsed by the AAP and the ACC and the AHA are from March 27, 2007. They are supposedly working on more. Who knows when they'll come out? So that paper is called Recommendations and Considerations Related to Pre-Participation Screening for Cardiovascular Abnormalities in Competitive Athletes, the 2007 update. Well, why is this an issue? This is an issue because parents are freaked out by when you come out and you say, something's wrong with your heart, I think you should see the cardiologist. Bells, whistles, panic, red face, passing out, all that good stuff, which, by the way, is a reason to see the cardiologist. So why is this as or more important than other concerns than parents and patients have? Because it's the heart. Of course, the heart runs everything. No heart, nothing. That's just my bias. So in the last school year, so this is the 2015-2016 school year. Rod Williams, this guy made the front page of the newspaper everywhere. 5'11", 300-pound junior offensive lineman. Very nice guy, life of the party, great guy in the locker room. Collapsed to the ground while waiting, just standing, waiting for a second, third turn to taking on a blocking dummy in the September 22nd, 2015 practice in Burke County, Georgia. First drill of the practice, 6 or 7 minutes in. School's athletic trainer, who Parker says monitors most of his team practices, administered CPR, which on a 300-pound lineman isn't the easiest thing to do, for 7 to 8 minutes while the paramedics arrived, took him to the nearby hospital where they stabilized him until he died on October 6th without regaining consciousness. Most likely, he had hypertensive heart disease, led to pulmonary edema, causing his lungs to fail. Temperatures were in the mid to high 70s, which around here is what, December? He had passed the school sports physical. This is the part that scares all of us. Passed the school sports physical over and over and over as he was a junior in high school. Nope, and yet still had hypertension and died. As the coaches and the athletic people in Burke County said, we don't know if there's anything else we could have done with the information that we had. We try to follow a protocol that keeps our kids protected as best as they can. It was a really, really unforeseen and unfortunate incident. Tony Graham, 6'4", over 300 pounds, freshman in high school. Right there should raise some questions. Wanted to skip his freshman team and tried to try out for his varsity team. 4 days before his 14th birthday, collapsed while partaking in, quote, light stretching exercises and a voluntary conditioning workout. As we all know, voluntary conditioning workouts, they're not really voluntary, but they are what they are. Inside an air-conditioned gymnasium. Team coach's trainer called 911. Paramedics arrived. They believed defibrillator was used. Went to the local regional medical center where he died 2 hours later. On autopsy, he had evidence of pre-existing cardiac disease, which has not been reported what further it was. We couldn't have been more proactive in terms of putting the kids in a safe situation. We were not in a position to mandate any kind of cardiac testing or things of that nature. Can never be proactive enough, but I feel all measurable precautions have been taken. There is now a database which is optional, which some people use, some people do not. National Center for Catastrophic Sports Injury Research, based out of UNC Chapel Hill. In 2015, there were 10 indirect fatalities, 5 of which were cardiac related. 2 high school students, 1 college student, and 2 that were in youth football. 15-year-old was jumping rope during conditioning and spring practice, collapsed, died of sudden cardiac arrest of unknown etiology. 13-year-old freshman was stretching prior to weight training, collapsed. Cause of death is pending, but believed to be pre-existing heart disease. 16-year-old was at morning football practice. Presumably, it was not too hot. Transported to the field house after having difficulty breathing. Died at the hospital. Cause of death due to heat stroke. Reports indicate the heat index was 109 at 11 a.m. That's a good Texas summer. Male 14-year-old sophomore offensive lineman collapsed during football practice. Died to complications from heat stroke. Body temperature was 105 upon death. Male 16-year-old junior defensive lineman felt ill during strength and conditioning. EMS was called. Nothing was found wrong. Fell ill again at home. But found to be extremely dehydrated, deteriorated, and died. He had complications of sickle cell trait. Male 17-year-old junior offensive lineman collapsed during practice. Believed to have died from pulmonary embolism to hypertensive heart disease. 13-year-old 8th grader was running during gym class, not even football practice, just gym class. Collapsed, transported to the hospital. Cause of death was hypertrophic cardiomyopathy. Sandlot football, good old 10-year-olds, was participating in his first football practice, was running, and he collapsed and died. Cause of death was an anomalous origin of the left coronary artery. 9-year-old collapsed during a break at practice. CPR immediately started, died shortly after. Cause of death was to congenital heart disease that was not picked up. The 1 college student that died in 2015 was a 25-year-old offensive lineman, collapsed during training after complaining of shortness of breath and chest pain. He complained of chest pains the previous day, but previous assessment did not find anything abnormal, so he was put back out on the football field. EMS arrived, CPR was started, died shortly thereafter due to cardiac arrest. Sudden cardiac death in persons less than 35 years of age is extremely rare. Apparently I have to be facing this way. It's likely responsible for over 2,500 deaths per year in the United States only. Yep. And the incidence ranges between 0.06 and 1.3 deaths per 100,000 person years. So not very frequent. Causes of sudden cardiac death in the age group that we see: hypertrophic cardiomyopathy, long QT syndrome, Brugada syndrome, arrhythmogenic right ventricular dysplasia, Wolff-Parkinson-White. These are all the things that we pick up when we're getting EKGs on all of these, the mass EKG screenings that we do. This is what we're looking for. Most common cause of sudden cardiac death is hypertrophic cardiomyopathy, which accounts for about 33% of the sudden death in cases. EKG is abnormal in greater than 90% of kids with hypertrophic cardiomyopathy. The 2000 recommendations focus primarily on mass screenings of high school and college-age athletes of all races and genders. We can extrapolate the information in this document to younger athletes, but is not specifically designed for younger athletes. Now, as we all know, hardcore athletics in Texas starts at about age 4. So we screen them. So this document recommends 12 items to be screened for, which can trigger further evaluation. A positive in any one of these 12 may be judged sufficient to trigger referral for cardiovascular evaluation. Medical history. Personal history of exertional chest pain or discomfort, unexplained syncope or near syncope, excessive exertional and unexplained dyspnea or fatigue associated with exercise, prior recognition of a heart murmur, elevated systemic blood pressures, family history of premature death before 50 years due to heart disease in one or more relatives, disability from heart disease in a close relative less than 50 years of age, specific knowledge of certain cardiac conditions in family members, including hypertrophic or dilated cardiomyopathy, long QT syndrome or other ion channelopathies, Marfan syndrome, or other clinically important arrhythmias. So when you get that EKG back and it says something funny up the top, when it does not say normal sinus rhythm, normal ECG, pretty much I'm going to get a look at it. On physical examination, heart murmur, femoral pulses, got to check them. We want to make sure that there's no aortic coarctation or narrowing anywhere in the aorta. Any physical stigmata of Marfan syndrome. Probably all of you have had some training and specifically looking at your basketball players. Hey, he's 7'2", he's a great center, but he just looks a little funny. Brachial artery blood pressure in a sitting position on both arms, please. Again, a positive in any one of these 12 items can be judged sufficient to trigger a cardiovascular referral. And why are we doing this? Virtually all lawsuits brought against physicians have been settled out of court prior to ruling. So the legal framework of physician liability has never been established. We don't know from a legal standpoint what the issues are. However, both the IOC and the ESC have recommended that all young competitive athletes, however you'd like to define that, should be screened with a comprehensive history of physical and a screening 12-lead EKG. Now I say this, both of these organizations are heavily based out of Europe. And Europeans have a much more robust medical system, also a much more robust screening system for their young athletes. But the percentage of young Europeans that play sports is much lower than it is here in the United States. Current customary practices here in the United States. In high school, there's no universally accepted or mandated standards for screening of high school athletes. It is district to district, city to city, county to county, state to state. Standards have been left to the individual schools, districts, or state boards. In college, most, if not all by now, colleges conduct pre-participation screens within their existing trainer and physician infrastructure. The NCAA mandates a pre-participation evaluation in all collegiate athletes in Division 1, 2, and 3 before their first practice or competition. The Olympics, the IOC is recommending pre-participation EKGs, and the USOC administers the pre-participation H&P following the ACC guidelines prior to Summer and Winter Olympic Games. If they find anything funny, then they get evaluated. Non-invasive testing is only if indicated. Why is this? Money. Costs. As of 2007, it's estimated the annual cost to establish and continue a screening program for just the high school athletes in the United States will be upwards of $2 billion per year. Obviously, this data is 9 years old. It'll be higher now. Cost of detecting each athlete with a suspected cardiac disease is upwards of $330,000. Cost for preventing each death is $3.4 million. You're going to have a hard time getting your school districts to foot that bill. This is taken directly from the recommendations. Quote, complete and targeted personal family history and physical examination, including brachial artery blood pressure measurement, is designed to identify or raise the suspicion of those cardiovascular diseases known to cause sudden cardiac death or disease progression in young athletes, represent the most practical screening strategy for implementation in large populations of young competitive sports participants in the United States. Medical evaluation should be performed by a qualified examiner and include the 12 key AHA recommended elements for personal and family history and physical examination, as well as parental verification of the medical history for high school and middle school athletes. Obtaining echocardiograms and or ECGs as part of a pre-participation screening remains optional. Such an approach is an obtainable objective and should be mandatory for all competitive athletes before their initial engagement in organized sports. Comprehensive screening evaluation should be administered again after 2 years for high school athletes. Again, these are just the recommendations from the ACC. I know we don't do that here in Texas. Controversies. So in Italy, they implemented a mandatory pre-participation screening program, and the incidence of sudden cardiac death decreased from 3.6 per 100,000 person years to 0.4. 2% of athletes screened were disqualified for cause, and of those, almost 10% had some sort of cardiomyopathy, whether it be hypertrophic or dilated. However, in studies from Europe, as well as small studies from the United States, have indicated that the incidence of abnormal ECGs run between 10 and 40%. This has led the U.S. as a whole to cite the financial burden as well as availability to medical resources as a primary driving cost for not implementing a universal ECG screening program. So, a recent study in 2011 presented a trial where 32,000 high school students in Chicago were screened, and they managed to get, by volume a discount, ECGs at approximately $10 per study. Using trained personnel, 2.5% of the ECGs were abnormal, requiring further evaluation, which included echoes. However, the reason not to go straight to echo is they take a lot longer to perform. They're a lot more expensive than $10, and they're hard to get in some places. I'm sure you guys have lots of questions. I have 30 more slides, but I wanted to stop now because, one, it's 2 o'clock, and 2, I know all of you are going to have lots of questions. Yes?
Where can you get the 12 items for screening?
So that is one in the 2007 recommendations, the pre-participation recommendations from the ACC, but it's also that, how many pages is it now? 4, 6? The UIL, the medical history form. All of those 50 or 60 or 80 checkboxes, those cover, if they fill out that form, all of those 12 items are covered. Yeah.
Have you utilized any of the EKG apps yet? Well, I mean, it's not directly
I like 12 leads, 15 if I can get them, sometimes 18.
I know that they
I-
don't our patients monitor their
Right. So those apps will do great for monitoring rhythms. So if you're looking at a supraventricular tachycardia, if you're looking at an arrhythmogenic right ventricle, if you're looking at Wolff-Parkinson-White, if you're looking at something that would potentially cause problems from a rhythm standpoint, those apps are fine. Things like hypertrophic cardiomyopathy will not be picked up by those apps, because there you're not looking at rhythm, you're looking at the morphology, the shape, and the size of the waveforms, which really can only be determined from an actual 12 lead.
So my question is,
Yes.
during my assets, say something was missed during the pre-participation exam, and now you have an athlete coming up to you with shortness of breath, like that, and you're like, okay, let's try to differentiate. This is just a conditioning issue. And
Right.
some tools and some, I guess, some suggestions, things for us to do as athletic trainers to kind of help rule that out.
Sure. So in general, as a cardiologist, if they're having problems during exercise, that is cause for concern. Because if they're not if they're passing out, they're having chest pain while they're exercising, they're under loading conditions. And if there is cardiomyopathy, if there is an abnormal coronary artery, if they have valvular stenosis, regurgitation, aortic stenosis, anything like that, if they have coarctation, any structural issue, you won't see it necessarily when they're sitting in class. You're going to see it when they're exercising, and they're going to present as shortness of breath, as chest pain, as not feeling well, passing out.
Just because we had a kid who ended up having canned sausage before practice, and didn't know the difference between reflux and
Yeah, I've seen that kid. I ate 2 pounds. I ate two pounds of chicken before. Right. So officially, as a cardiologist, if you're having problems during exercise, you probably should pull the kid out, and you probably should get the kid evaluated either by the general pediatrician or by a cardiologist. I would be hesitant to rely on an iPhone app for an EKG.
that's why I was wondering if you had any.
I do not have any experience with them. I suspect from a medical legal standpoint, they've not been validated. I suspect they haven't been tested. And I don't want to open you guys up to any more liability than you already are by saying, yeah, sure, put a couple leads on, put it into your headphone jack, and let's see what happens.
Well, I just know some athletic trainers who do 12 leads.
Right, and 12 lead, but a 12 lead is totally different. That's a totally different situation. An iPhone app is going to give you 1, maybe 2 leads. It's going to give you rhythm. Quite honestly, if you're trained to use a stethoscope, you can tell me what you can tell what his heart rate is, and you can tell what his rhythm is, and you can tell if it's regular or if it's irregular. An iPhone app, I'm not sure. I haven't seen them, but I'm not sure it's going to give you much more information than what you can already do by auscultation. Yes, sir. Not specifically with energy drinks, aside from the fact that I have a whole cadre of kids that get tachycardic and come see me because they're having palpitations. Well, what are you drinking? I'm drinking, I have a Starbucks on the way to school, and then I have 3 or 4 Monsters, and then suddenly I'm tachycardic at lunch. Okay, well, I think I got this one figured out. I've seen problems with supplements. I've seen a few kids who have developed dilated cardiomyopathies from presumably without any other family history or any other identifiable etiology. Only thing we can come up with is either the supplements they were taking or tainted supplements. We took them off supplements and they regressed. So I don't like supplements. but that's neither here nor there. That's a whole nother discussion that I'm sure you guys have, because I'm pretty sure probably most of you guys don't like supplements either, because you just don't know what's in them. But no, specifically with energy drinks, no, I haven't seen any problems except for tachycardia and palpitations.
Of the ones, the diseases that you went over
Mhm.
earlier, how do they express themselves over time? Like if I check a child starting at say 5 years old,
Yep.
and could they, if I know they're clear of everything at 5, will they get? Is it possible to develop any of those along the way?
Yes, all of those. So this gentleman asked for the diseases that I specifically commented on, your hypertrophic cardiomyopathy and all the arrhythmias. If you start seeing the kid at 5 years old, can they develop any of those down the road? The answer is yes. So hypertrophic cardiomyopathy can develop over time. It generally is a genetic condition, and if they have a predisposition to it, they can develop it over time. A lot of times we don't detect hypertrophic cardiomyopathy or hypertrophs until they're well into their adulthood, because they don't start having symptoms. They don't start having symptoms until you start obstructing, and until your muscle mass either outstrips what your coronaries can get to you when you're exercising, or till you start obstructing your left ventricular outflow tract. And all of those arrhythmias, we suspect are genetic. A couple of them we know are genetic. You can have so like Wolff Parkinson White, for instance. If you get an EKG, you'll see the delta wave. Have you guys all been talked about what delta waves are and the upslurring of the QRS? Okay, so basically what that is your ventricle, when your ventricle fires, you get this big spike on the EKG. So you get the medium, the big spike you got the small spike, the big spike, and the little spike. Small spike is the P wave, big spike is the QRS, which are the ventricles. Medium spike is the T wave or reset. With WPW, you get the QRS complex is wide, and you get a slurring into the QRS. You don't necessarily you can have WPW without having SVT or supraventricular tachycardia. If you have WPW or you have the accessory pathway, you have about a 1% chance per year of developing SVT. So a lot of people with WPW don't ever have SVT. That doesn't necessarily mean that you just watch them. A lot of people will go and fix those kids with SVT, with WPW, even if they've never had SVT, just to get rid of to normalize the EKG and to decrease the chance of developing SVT. But that, again, that's up for much debate also. But yes, they can develop any of those, even if you're seeing them, which is why we recommend as long as you're participating in competitive athletics, you continue to have screening.
I've been part of this conversation before, implementing the screenings in the school
Mhm.
district. The two big concerns were, one, disqualifying kids who would never have seen an issue, and two, missing a diagnosis on a kid and the liability of that.
Right.
So can you speak to the validity of those concerns at all?
Sure. So the question is, when you guys have participated in these screening programs, I'm assuming EKG screenings or just questionnaire screenings, making sure the EKG screenings. One, the concern is disqualifying kids who wouldn't necessarily be disqualified
Or would never see an episode.
or would never see an episode. So as a cardiologist, we do a really good job. My feeling is you guys should never be the final arbiter of disqualifying a kid. So if you see an abnormality, if you see something pop up, if you see an EKG that you're concerned about, if you see something on the history and physical, you should refer them to a medical doctor, whether it's their pediatrician, whether it's me or the cardiologist. And let us be the heavies. Let us, because we see, probably you've sent to me this past month, I've probably had 10 or 15 kids, all with abnormal ECGs. I've disqualified 0 after further testing. So EKG is abnormal. Okay, bring them in here. We'll get the 12-lead EKG. We'll do a 24-hour Holter monitor. We'll do a 30-day event monitor. We'll put them on a treadmill. We'll get an echocardiogram. Whatever needs to be done, we'll do it. Because EKGs are fabulous screening tests. They will catch everything. But the problem is 50% of what they catch isn't real, depending on what you're looking at. So you let us figure out, sort of sift through all that stuff. You get the EKG because it's cheap, it's easy, and because you can get the kid to sit there for 5 seconds while it's done. And then you send them on to me if it's abnormal. The concern about missing stuff, you're only as good as the information you're given. Even we miss stuff. You know, if the parent lies, if the kid says, oh, well, yeah, I didn't actually pass out. Is that real or not? You are only as good as the information that the kid will give you. If the kid's lying to keep his, if the kid is lying to keep his spot on the team, if basketball, the kid's playing AAU basketball, no trainers. I was having this discussion just 30 minutes ago. No trainers on the court. Kid has a concussion. They're coming back to you at the beginning of the school year. No, I didn't have a concussion. You don't know any different, right? Wide receiver, running all summer. Wants to be the number one. Wants to be the X receiver out there. Well, he's got to run a 4.4. Okay, so he's working all summer, doing those wind sprints, trying to get that done. Passes out when it's 105 out here. Now I'm fine. You don't know any different. The best you can do is look at those screening stuff, get an EKG, if warranted. So you're never going to be able to catch them all because people are going to lie, unfortunately. You know, I have patients lie to me every day. It's a fact of life. You know, the parents sitting there, nah, that's not, you know, Mr. Jones told me, Trainer Jones told me that you did this. Well, that's not real. You know, who am I going to believe? So you can only work with the information that you're given, unfortunately. And
Stay on schedule, y'all.
Yep.
If you have any other questions, we can meet y'all in the lobby to help answer those.
Okay. Thank you very much for your attention. Couldn't keep that stupid thing on my ear. Oh, no, I've got.
All right, we are at the EBP portion. So if you guys want to flip to the back, and the back is the quiz. You must fill out the quiz and you must do the eval for this next talk. And then that is what you will turn in conjunction with signing in the back, outside on the papers. So I'm here to introduce our next speaker. Most of you know him. A few of you like him. He is one of our outreach athletic trainers covering the Southeast region. He is also Regional Director 6 for Texas. Is James Bubba Wilson up next.
Okay, am I on? Hello. Hello, Kale. Is this thing working? There it goes. I can unfortunately hear myself. All right. So interestingly enough, part of this talk is going to piggyback off of what Dr. Lorch was just talking about. And then a lot of it won't. So we're going to talk a little bit about a lot about the emergency action plan today, and kind of from a slightly different point of view. So financial disclosure statement. I have no relevant financial or non-financial relationships. Okay, we're going to talk about that a little more. Another disclosure, my viewpoint today that I'm going to say has not been endorsed or approved by Memorial Hermann, because I'm going to throw some people under the bus. Okay, you should expect that from me. All right. So, however, financially, I did get to go to Alaska on a cruise a couple of weeks ago. Financially, that cost me a bunch of money, especially when I got the credit card bill for my wife and daughter's spa days on the ship. And secondly, tomorrow, my daughter's single comes out on iTunes and other platforms. I'm not saying buy it. but financially, I spent a lot of money. So, and it's a good song. It's probably one of her best, and I don't say that as her dad, because I've known a lot of Little League parents, and I don't want to be one, but it is a real good song. Okay, so we're going to talk about the emergency action plan, and to me, there's 3 phases or parts of the emergency action plan. We're going to discuss all of them. Now, I'm going to breeze through a little bit of the first 2 to get to what's important, okay? So just bear with me. You've got to do my eval and turn it in. You've got to take the test. You don't have to turn it in, but if you're really nice on my eval, I'll give you the answers to the EBP aspect of this. And it's going to be the best talk you hear all day because it's EBP and it's mine. So, all right. So what's phase 1 of an emergency action plan? It's the before. This is what we got to post, right? This is the plan. All right. That's what we post in our gym, in our field house, at our baseball field, at our softball field. This is what we have to have up. Okay. Some basics on it. This comes out of Senate Bill 82 in 2007. That might be a test question. All right. Section 33.202, that's not a test question. But it just in that section, it discusses CPR and AED training. We all know about all these beautiful things. You got to perform your drill every year. Test question. Okay. And you remember, we can now have to have our student athlete education that goes with this. So some specifics for yours. Is it posted? It's by law, it's got to be posted. I know a lot of schools that you don't see them. Those things are ghosts, man. They don't exist. Okay. So how do you label yours? Who does what in a drill? And I'm not going to belabor this, but don't put that Bubba Wilson's going to open the gate on the north end. What if Bubba Wilson's not there that day? Make it generic. Okay. Coach is going to do this. Student can do this. Athlete can do this. You can pick from 100 athletes to go do something. It's not going to be Johnny because Johnny's never there. I don't know why you put him on there to begin with. Okay. How detailed in it? That's your decision. Sometimes we get caught up in minutia. Sometimes less is more. Okay. Is it practiced or drilled? Again, this is by law. We got to practice this. We always ask our coaches when I was at the school, please tell me you're drilling because I don't want to soil my pants when you say we need you in the pool. Somebody's collapsed. Oh, just joking. It was our drill. Okay. And do you document this? I think you should document that you did your drill. Who did what? Okay. How long did it take the AED to arrive? By law, what's the number? How many minutes? 3 minutes. Okay. So you should be able to send somebody, your fastest coach, in and back to get that AED. How long did it take? Phase 2, this is the during, okay? This is the fly by the seat of your pants aspect of the emergency action plan. You can't write this down, okay? So I just got a few questions or thoughts about this aspect of it. How many of you check your splints to make sure they don't have any holes in them every year? You're inflating them, deflating them, whatever it is to make it work. Not everybody's doing that. So now all of a sudden you need them. Oh, hell, there's a hole in them, okay? You're in trouble. Hey, what happened there? What is the address of the location of the playoff venue that you're playing at? I'll be the first to admit, I didn't always know the address of where we were going to play. And I hope to God the administrator on duty knew where we were, but they may not. So now if I'm going somewhere neutral site, what's that address? I'm going to have it because it may not show up for the EMS system as to where you're calling from. How are you going to remove a face mask? What tools are you going to have? Again, these are fly by the seat of your pants except for that first one. Are we going to remove the equipment on the field? I'm not getting on that soapbox, but what are you going to do? Okay? Do you carry a spine board? If you do, I'm going to ask you why. All right? Because to me, if you need a spine board, they're going to the hospital, use the ambulances. But what's your relationship with EMS? If you deal with the city of Houston, they suck. Okay? The relationship sucks. It's not good. In my situation where I've been, I've dealt with 2 different EMT entities. City of Houston when I was at Kingwood Park, but City of Humble when we played our varsity football games or had track meets over at Turner Stadium. How I dealt with City of Houston was vastly different than how I dealt with the City of Humble. City of Humble said, what do you need? We got you. Whatever you tell us what to do. And I won't get into the City of Houston. Okay? Who rides with your athletes if they're going to the emergency department? Is that set up in your emergency action plan? It should be. If you're taking a kid from your field to the hospital and say it's practice and mama's not there, I sure hope they're not riding alone. So who's going to go with them? Football practice at that point, if that's where it's from, doesn't matter as much in taking care of that kid. You may not be able to go, but a coach can go with them. Who's making the phone calls? 911, parent or guardian, administration. You got to let them know what's going on. Okay, we talked about splints. How are we going to immobilize? Again, this is fly by the seat of your pants. What's this fracture look like? What do I have available? What else is going on determines all this. We're going to put them in an IROM. We're going to put them in a fracture walker if it's an ankle. Okay, slings. What kind of splint? AED, Senate 7, same year, 2007. Not a test question, but good to know. Is your battery good? Your pads good? Have they expired? Okay. Who's doing the weekly, monthly checks? That should be on a log. Okay. I don't tell you that to tell you how to do your job, but if something happens, they're going to ask for those. A good attorney will. Okay. So let's say you have this. If you listen to Dr. Meeks this morning, this is in essence what? A knee dislocation, right? I want you to look at what's on the helmet. We'll get back to that in a second. What's the best way to handle that? Is it that right there, no immobilization with an ice bag wrapped around their knee, holding it while we drive them in to get it looked at? We're in a church, but the answer is hell no, okay? That's probably a better way, and I don't say that because I'm friends with Kaplan and Rowland and Dr. Lowe's, our team physician. I work for him. I like how they decided to handle that knee injury right there. That's not moving. They've immobilized that knee injury. I can't remember what that was, if that was a dislocation or a patellar tendon rupture. Doesn't matter. Either way, they're unstable, right? They've handled that best. So how are we going to get them off the field? We're going to walk them off, carry them off, cart them off, sports chair, love sports chair. Okay, EMS, when are you going to activate them to come get them? How are we going to use them each and when? Again, you're flying by the seat of your pants. So again, you have this. Are we going to do that, which is what they did? That's the same kid, okay? There's nothing protecting that lower extremity right there. Who does not evaluate a knee injury on the field? I'll put it that way. Good, not a single hand went up. So how do they not know that his whole lateral side's gone? Why did they not immobilize that kid? Okay, why did they not do that? I'm not talking about that right there. That's the same program, but they're going to take all his pads off for a C-spine injury, but they're not going to immobilize his knee. Okay, I wasn't there, but I'm going to throw him under the bus because that doesn't make sense to me. Okay, we're going to pull all the pads off because that's best practice. What's best practice for a knee dislocation? It's not walk them off the field and drive them in with nothing protecting them. Okay, so let me step off that soapbox. How do we communicate on the field? We do the old-fashioned way and yell at each other. Okay. Hand signals, don't like it because my kids are going to think we're stealing third when I needed them to go give me some tape. All right. Radios. Do we use them? Is it athletic trainer to athletic trainer? Is it athletic trainer and admin? Athletic trainer and who? Okay. If you use them, great. If you don't, great. Don't care. But something to think about. Policies and procedures. How are you going to handle sickle cell trait? You're going to administer O2. That's a whole different lecture, but that's the best practice for sickle cell. But we're dealing with minors in a public school, private school setting, little different animal, but something to think about. Asthma, do your kids have their inhaler? No, but they've got their buddy, so it's probably going to work. All right. Allergies, what if they need an EpiPen? Have we got that set up and ready to go? Diabetes, that kid that needs glucose, glucagon, is that ready to go? Okay. Now you have to be trained through the TEA for diabetes management. Your independent school districts can give you that training. It's online, it's boring, but you get a certificate and nobody bugs you again. Okay? Concussions, that's part of your emergency action plan. How are we going to handle this concussion? Right now it's good, he's trending bad, we need to send him. Emergency action plan goes in, so that's part of it. And remember, your medical history is part of your emergency action plan. Okay? Bubba's allergic to ant bites. Our field sucks and Bubba's laying in a pile of ant bites. Benadryl's not going to cut it. We use an EpiPen. Remember, that's an EMS call as well, right? Okay, so we've planned for this, right? We're ready if this happens. We're ready, fortunately, unfortunately, depending on your outlook. Hope you never have to do this. We've planned for that. We want this, right? We want to celebrate that everything went good. But what if, hey, what are you doing? What if you get that? Are we prepped for that? Or what if we have to deal with that? Okay? I know it just got heavy, didn't it? All right? But what if this happens? What if we use that AED, but the outcome was good? Okay? So phase 3 is the after. I can't say nobody, but if I did a show of hands in here, maybe 1 or 2 at best would go up that somebody has the after part of an emergency action plan in place. Okay? I know the majority don't. The reason is we don't think past part 2. We want everything to work. And even if everything works, we need to think past part 2. But what if it doesn't? Okay? So should an emergency action plan address this? My opinion only, not Memorial Hermann's. Yes. Okay? We plan on the front end, we should plan on the back end. It goes without thinking about it, but we don't think about it. And I'm not blaming anybody. I didn't think about it, and I'm going to tell you why. So how many do? You basically don't. Okay? Not to argue that. So this is the different point of view about the emergency action plan. We need a post-catastrophe plan or a post-incident plan where CPR or AED was used, but the outcome was good. Okay? We need that third part to be in place. We need an after-action plan. What do we do if we have that catastrophe? There's things that need to be in place for this. Okay? Loss of life, paralysis, loss of limb, and it's not on there, good outcome after using AED or CPR. Okay? So the genesis of this whole talk, get to it, Bubba, shut up. Okay? The partner schools that I've had, there were 2 deaths in just over a year of friends of mine that had to deal with this. Okay? I got lots of time on my hands when I'm driving between school A to school B. I create these things for me to do. I've had experience on 2 occasions with the death of an athlete, or 1 occasion with the death of an athlete, and then I rendered aid in college, several of us did, to a classmate who died. Okay? So I've dealt with this differently. I wasn't the athletic trainer in charge or the coworker in charge, but I've dealt with this already. Doesn't make me better. I've got a little different perspective of it. Okay? So what are the components of like this post-catastrophe or post-AED CPR use emergency action plan? Well, if it's a C-spine or an AED use, we got to secure the equipment. We may need to go to the hospital after a C-spine and get the helmet, shoulder pads, and lock them up. Why? We know it doesn't change that they've got a C-spine fracture. The helmet didn't cause it, but the attorneys are going to want to see it. The AED should be locked up in a cardiac incident. Okay? Administration should come to you and talk to you. Hey, Bubba, I know you did all you could do. You tried your best. It didn't work out. I'm sorry for your loss. Or, hey, great job. You did everything. It worked out right. We're going to go further in this. It should be written to say, hey, please give me a personal accounting of the events to the best of your knowledge. And we're going to go in further detail on these. Who gets to contact the press or talk to the press? It isn't going to be me or whoever it was. I can guarantee you that. We need an after-action review. Now, if me and my coworker call the ambulance for a kid that's asthmatic and he's stupid, he didn't bring his inhaler and he really just needs a nebulizer treatment and it's no big deal, our after-action review was, well, that went well. He's just an idiot, okay? But if it's bigger, it needs to be more in depth, okay? And we're going to talk about counseling. I'm not going to get into that right now. And time off, we'll talk about that. Cause of death. Cause of death is huge. If it's that, cause of death is a public record, okay? You can find that, and that will change how you do things. And if you know cause of death, and you've already had 1 after-action plan review, which you should have, and you get cause of death, you should have a second. It may change what you need to address, okay? So let's look at administration visit. To me, it should be face-to-face. Check your mental health. If you look at the stuff in the NATA right now, we need to assess our athletes' mental health. Hell, they're all nuts. We know that, okay? Assess my mental health after I just dealt with the death or the paralysis or even saving a kid's life. Am I okay? Your school counselor, she already knows I have enough credits to graduate. I've already graduated. That's their job. It's not to come by and say, how are you doing? They bring in grief counselors for the kids, and every idiot grades 9 through 12 are going to go see him because they all say they knew the kid. They didn't know the kid. About 50 of them did. But all 1,200 are going to go see him. Okay? Bring in somebody or go see somebody training. We're going to get further detail on that. It's not a phone call. I think it's got to be face-to-face from your administration. We'll go over what needs to be done next, okay? So what are we going to do with the equipment? Hey, there we go. What are we going to do with the AED? So, Bubba, make sure you lock it up. So-and-so from the district's going to come pick that up and analyze that data. Okay, keep it locked up until they get here. Again, give me your accounting of the event, type it up, save it for your records. Who does that go to? What's the time frame that needs to be put out? Okay, is it on your campus or is it somebody, central administration, that gets this? And again, is there a time attached to it? I don't think it needs to be 2 weeks from now. It needs to be in a couple of days at the most. Okay, contact with the press. Do you or do you not speak to the press? In 99.9% of the districts, you will not, and I think that's a good thing. Okay, they have somebody to take care of that. So you get that phone call, we'd like to talk to you about this. All inquiries go through so-and-so. Who is that person? That should be written down. Okay, you know it goes through so-and-so. Okay. So we got to go over it after action. All right. We got to go over the event. We're going to talk about what happened. Who needs to be at this meeting? Does your athletic director? Does your principal? Does your school nurse? I'm going to tell you your school nurse probably doesn't unless she was involved in it somehow. All right. But who needs to be involved with this meeting? That's for you and your district or you and your administration to decide on. What went right? Okay. What went wrong? And I've got an asterisk. Wrong was the catastrophic event, the death of the paralysis. You're not blaming yourself in this, okay? So really, I'm going to tell you, don't worry about what went wrong. We're going to worry about what went right. Now, what went wrong? Oh, wow, they're having road construction that we didn't know about. You can't control that, okay? But you can control if your gate lock is rusted and you can't get it open, okay? We can't control that EMS went to the wrong entrance, even though you told them, look for the kid in the bright orange shirt waving their arms at the corner of here and here, and they go to the other side. Okay? Well, you can talk about those things, but don't talk about what you did wrong yourself. And what can we do to improve? Do we need another AED in this vicinity because it's really far? Do we need to make sure this gate doesn't get blocked by our idiots maintenance guys while they're mowing? Whatever it is, okay? And this needs to be done in a timely manner. Again, it needs to be done probably within a week. I'm just guessing. 2, 3, 4 weeks down the line, we forgot a bunch of the issues, okay? Or you write them down and you lose them in the pile of other crap you got if it's depending on what's going on. Counseling. This is controversial, but this is what I feel really strongly about this aspect of it. I think if it happened to me and I'm in a school district, they should say, again, Bubba, you did everything you could. I'm sorry it didn't work out. Within this amount of time, you must have a appointment scheduled with this psychologist at the school district expense. This is a work-related issue, is it not? It's workers' comp, okay? For us, the healthcare provider. You must go see this person. It's not a campus counselor, all right? Got to do it within a certain number of days. And much like the best analogy I can give, much like an officer-involved shooting, they go to desk duty, but then they must get a psychological eval to see if they're fit to go back to work, okay? Let's just say I saved someone's life with the use of an AED or in CPR. Am I okay to do it again tomorrow if I have to? I don't know. It's like saying, hey, I'd do this if somebody broke into my house. You're lying because you don't know what you would do until that time came. Okay? I don't know how I would respond. So if I do this and it was good and or bad, can I do it again a week later, a month later, a year later, 10 years later? I don't know, but it's a public safety issue. Let's make sure I can perform the duties of my job. Okay? So I think the district should pay for that, and it should be a minimum one visit. And they say, I think you're good. Great. If not, you need to come back and talk to me. That's all on the district's dime, not on yours. Okay? There's something called critical incident stress management. In theory, the NATA is going to roll something out in the next couple of weeks. We'll see what happens. I'm not real optimistic. Okay? It's peer-to-peer counseling. They have this for firefighters, first responders, okay? So if they go to deal with a bad wreck and there's death and mayhem and all that, you can get peer-to-peer counseling. You must be trained to do this, okay? I want to start a chapter for athletic trainers in the Houston area. So I'm looking into that. Nobody knows how intimately we know those kids besides us. I've known that kid since the 2nd grade. He's now a sophomore, and I had to do CPR on him, now he lived, I may need help. So it'll be somebody trained in this peer-to-peer counseling that's an athletic trainer that can come call me and say, hey, I saw where you had this incident. How you doing? Let me talk to you. I think I'm okay. Call me back in a week. I don't know how the training works and how that goes. Or they call and talk to me and go, dude, you're screwed up. You need to go get some help. Well, I've already got that scheduled. Great. I'll check back with you. I think there needs to be something in place, athletic trainer to athletic trainer. Okay? And again, NATA is going to do something. I want to do something and then take it to the SWATA level. I kind of want to get ahead of the game if possible. Brad, are you listening? We're going to talk about it. All right. Hey. So time off. Oops. I think it's a personal decision. I don't think you should take off just because the district says you should take off or your employer says you should take off. I think you should take off because you feel like you need a couple of days or a week, or we got to not go crazy. I need a year. All right. But I think you need to be able to take off if you feel like you need to get away and go through some things in your mind. That's fine, but it should not be mandated. Some people want to get right back on the horse. Others want to stay away from the horse for a while. Okay? I don't think if you take off that it should count against your state or local days. This is a work-related incident. Cause of death, we talked a little bit about that. Do we know? Again, we can find out. It's a public record. I don't know where to look. Somebody good in Google can figure it out. Okay? But I figured I could do it if I needed to. I'd like to know the cause of death if possible. Because maybe we don't need to change the quote-unquote full emergency action plan. Maybe we need to change how we do paperwork. Because how many we get that bring in the blank medical history, but yet the physicals have been signed and they're cleared. We shouldn't accept that. It should get filled out. But maybe we need to change some of the questions. That's a Dr. Lorch thing for some of that, okay? Do you get short of breath when exercising? Yeah, I'm fat and out of shape. Do you get short of breath when exercising after you've acclimated to your sport? Different question. So maybe we need to do stuff like that, okay? Now, knowing how they died obviously helps in how we may have to handle this in the future. Certain cardiac abnormalities, nothing's going to change. But we did our best, okay? So after action review number 2, only required, in my opinion, if the cause of death becomes known. Okay, so now we know what has happened. Okay? Dang it. New information is brought forth, or we got unsettled or tabled information or issues from the initial after action review. So, hey, we need to table this. We need to go look at this. We need to come back and revisit that. These things should not be left unanswered. So additional take-home information. I'm almost done. You get your quiz. Okay? I think it's okay to contact the athletic trainers and coaches involved in the catastrophe. Call them. Hey, I'm thinking about you, man. Call me if you need something. Okay? With the individuals I know, as soon as I heard, I was texting and/or calling and saying, I've heard about your loss. I'm sorry. If there's anything I can do, let me know. Yeah, I'm genericizing this somewhat because I'm not going to get into the personal aspects of it. Come by in the next couple of days, okay? I put coaches in here, and I didn't put it earlier, but in one instance, for sure, coaches were helping with CPR. Do they not need a psychological eval too? What if their next kid drops on the basketball court or the soccer field or on the baseball field? Do we need to make sure they can function as well? All that team of people that were the caregivers and involved, they need to get taken care of as well. So you can email them. Okay, this isn't an administration thing. This is peer-to-peer. Email them. Phone call, text, carrier pigeon, whatever works. Okay, reach out to them. That's the big thing. If you talk to these individuals, and I've spent a lot of time talking to a bunch of them. Hey, thanks for the phone call and the voicemail. Sorry I couldn't get back to you, but it meant a lot. I don't know that you'd find one of us in this room or elsewhere that say, dude, I didn't want to hear from you. Okay? They want to know you got their back. Hey, don't worry about it. I got your game tonight. Do something like that. All right? So let's review. We're almost done. We got to all have an EAP by law, right? Nothing we can do about it. We all need to also have a post-catastrophe plan. And I'm going to eventually say none of us do. Okay? We need to have an after-action review. We need to assess the mental health of those involved. Make sure they're okay to do their job. All right? That's all I got. Thank you. All right. We will do your test questions. And then if there's any questions, we'll go from there. And if not, that's fine too. All right. So question number 1, I don't remember what it is, but I know the answer might be the first letter of the alphabet. Don't cheat for them. This is star testing now. Everybody do your own work. Okay? Everybody there and ready to mark? So we got the first letter of the alphabet. There's a pattern here, people. Pay attention. Second question the answer to it might be the second letter of the alphabet. Strongly advised to go second letter. Strongly advised. Third question is most definitely the third letter of the alphabet. Grade your own test. All right. Anybody have any questions off of what I just talked about? You can palpably feel the room kind of drop when I start talking about people dying and that stuff. It's interesting. Okay. Anybody got any questions? Yes. What does it say? Is that B? Okay, then I was wrong. Y'all all failed anyway. B. I thought I went A, B, C on that. So I guess it would pay to look at my own test questions and see what they said. So, all right. Anything else besides right answers required? Y'all are good? All right. Thanks.
Okay, can y'all hear me? Yep. All right, so about a month or two ago, I went to a wedding. I was a groomsman at a wedding. And we finished the wedding, we all went up, we were gonna celebrate. And so we went to kind of the side room while everyone was clearing out of the, I guess the church, and we were going into the reception area. And so when I got in there with our wedding party, there was a bucket of champagne and a 24-pack of 5-hour energies. I was thinking to myself, what kind of wedding am I about to go to tonight? So when I thought about that, I also thought about all the high schools I've been to, athletic training rooms, where I see energy drinks, sodas, coffee, what have you. And so I figured I'd do a talk on caffeine and nutrition performance, or sports performance. Something there's a lot of misconceptions about, and so I figured this would be something good to clarify and explain. So as I started to read the information, I started to realize that normally when you pick a supplement, you find there's probably 1 or 2 review articles on it, and you can start to go into, dig a little bit deeper and find individual studies. And that wasn't the case with caffeine. All of a sudden it was 20 review articles. And it wasn't just review articles, review articles on other review articles and on subsections of caffeine. And so I started to realize I can't get near the depth I need to for this. And so how I'm gonna go about doing this is we're gonna do a talk. We're gonna touch on a lot of different areas of caffeine. But for those of you who know me, I love social media. So what I'm gonna do is while we're doing this presentation, I have a Twitter account. It's up there at the top, @bsinger10. And I'm going to be tweeting out, or Paul is going to be assisting me, tweeting out all sorts of different articles, full text articles, abstracts, as well as websites, other materials, slides, etc. So if you find a particular topic interesting, so whether it's caffeine in weightlifting or caffeine in sports performance, there's articles on there. And you can actually go back and review them if you want to go further in depth. If you're not on Twitter at all, that's fine. You can actually Google me right now. You can Google @bsinger10 and you can follow along still, even if you don't have a Twitter account. And you can pick and choose the articles that you're interested in. If you're on Twitter, I would love for you to follow myself, our HBU account, and Paula. She's our other dietitian that Dan did not reference. Paula's leaving us soon, but she's still with us right now. And so follow along. I would greatly appreciate it, and hopefully you find that interesting. All right, so we're going to talk about a number of things: sources of caffeine, mechanisms of action, dosing, sports, side effects, etc. So caffeine's been around for a long, long time. It's been used for a wide variety of reasons. Obviously, we want to try and stay awake, but also health, sports performance, etc., etc. Early in the 1900s, we would see coaches actually mix caffeine with cocaine, heroin, and other mixtures for sports performance. Okay, caffeine stuck around, the others did not. And that actually went into these forms, right? So we obviously had tea and caffeine or coffee all along, but it's developed into sodas, which were actually originally, Pepsi was actually originally promoted as a performance supplement for race car drivers. Okay, so it's been around for a while. Then it developed into energy drinks, energy shots. Then we had pre-workout supplements. We now have sports drinks, which have caffeine in them. We have sports gels. We have shot blocks that also have caffeine in them. We also have things such as caffeine powder, which has been in the news in the last few years. Even things like Excedrin or other aspirin will have some caffeine in there as well. We also have, and for the military, we've been using it, we have caffeinated gum. So we have all sorts of different sources of caffeine. Okay, so what happens? When you consume caffeine, it goes to the GI tract very, very rapidly, and we see traces of caffeine in the blood within 10 to 20 minutes. We see it peak in the blood usually about 60 minutes. So typically the recommendation would be have it about 1 hour before. Now, caffeine stays in the blood for a while. So if you consume it, you actually get performance benefits from it for a while. So because it stays in there for about 3 to 5 hours before it finally starts to decrease. So the half-life is 3 to 5 hours or so. Okay, so it also has the effect that it crosses over the blood-brain barrier. So meaning it can affect the central nervous system. So how does it actually affect the body? So originally, and this is something we still hear to this day from all sorts of different people, the original studies showed that when people consumed caffeine, that there was an increase in fat oxidation, meaning that people would burn more fat during their sports and they would utilize less carbohydrates. Okay, now remember that we have a finite amount of carbohydrates stored up in our body. And so the lower that storage of carbohydrates gets, the more fatigued we feel. So if we can spare those carbohydrates, then that means we can go longer before we feel fatigued. So the idea was we'll take in caffeine, we'll spare muscle glycogen, we'll go longer before we hit that wall. Okay, this is also where we started to come into fat burners loading up with caffeine and weight loss supplements loading up with caffeine. Okay, but as further studies started to come out, what we saw is that it didn't always happen that way. With lower doses of caffeine, there was no fat oxidation or no differences in fat oxidation, yet people still improved performance. Additionally, there would be some very, very high levels of caffeine intake, which would increase fat oxidation, but no performance benefit. And then lastly, we'd see some studies which were an hour or 30 minutes, right? And for a 30-minute race, we're not really worried about carbohydrate depletion or glycogen depletion. That shouldn't be a factor. And yet caffeine would still improve that performance. So we started to realize, okay, maybe it's not so much fat oxidation that's the role, maybe it's something else. And so we talked about it earlier, so it's actually more central nervous system is what it is. So caffeine acts as an adenosine antagonist. Adenosine meaning it's a neuroreceptor, and that receptor tends to cause fatigue. It tends to make us sleepy, drowsy, tends to make us a little bit less active or feeling quite as energetic. And so caffeine blocks that, and it has the opposite effect. So now we feel more wakeful, we feel more vigilant, we tend to have more energy overall. Okay, so it's not so much fat oxidation, more on the central nervous system. So how much caffeine do you actually need? So how much do you need? How much is recommended? What I'll use is, we use milligrams per kilogram. That's kind of our starting point. Now, this is also dependent on the sport. It's dependent on the individual, their tolerance. So there's a variety of things that play into this. But the weight of the individual is first and foremost to kind of dictate how much would be appropriate. So we use milligrams per kilogram. So if you're curious, you could divide your weight by 2.2 into kilograms, and that's how we start. I'll use a 165-pound athlete. Okay, so they're 75 kilograms. Again, original studies, they wanted to hammer it home. Does caffeine work or not? So they'd use 6, 9, sometimes 10, 13, 15 milligrams per kilogram. Okay, so 6 to 9 milligrams per kilogram for a 165-pound athlete would be 450 to 675 milligrams. In terms of Red Bulls, that would be 6 to 8.5 Red Bulls. Okay, 6 to 8.5 Red Bulls. Sometimes they would use 13 to 15 milligrams per kilogram. Okay, think about that. They wanted to hammer it home. Does caffeine work or does it not? You use a lot and you find out pretty quickly. All right, so then they progressed. All right, so we know it works. We're going to move down lower and lower. So now they use it as 3 milligrams per kilogram. Okay, that's a little bit more appropriate, or at least a decent amount. So 3 milligrams per kilogram for a 165-pound athlete would be 225 milligrams. That equates to about 3 Red Bulls or so, okay? Or that's about 12 ounces of coffee from Starbucks. Okay, when you put it in that terms, that doesn't sound quite so bad. The original one I mentioned will probably be about 2 venti cups of coffee from Starbucks. That's a heck of a lot of coffee. Okay, then they found out that it's actually even less. So when athletes, what they realized is endurance athletes, triathletes, marathon runners love to use Coca-Cola, flattened Coke, late in races. So what they'd see is late in races, these athletes would drink Coke and they'd report some sort of performance benefit. So they did the research and found that when you're fatigued, when you're glycogen depleted, so late in the game, late in a race, you can use significantly less caffeine. So now 1.5 milligrams per kilogram, and you can have a positive response from that. Okay, so now that's 1 Red Bull, or that's an accumulation of a couple of gels. So remember I mentioned caffeine has a half-life of 3 to 5 hours. So an endurance athlete might take in a gel or a sports drink that has 50 milligrams of caffeine, and they do that once or twice an hour. Now they have the same response, right? So it doesn't have to be Red Bull. I just use that analogy, right? So it is possible to take in a small dose and provide a performance benefit. So if you're curious which things provide caffeine and how much, a good website for that is Caffeine Informer. You can actually search any caffeine product or a lot of them, and they will pull up how much caffeine is in there, and they will even generate different types of products in that same subsubject. So that's a good place to look or start off if you're curious how much caffeine is in certain products. Okay, what about kids? Most of us are going to be high school athletic trainers, so what about kids? 12 and under don't really need caffeine. We recommend no caffeine at all. If they take in trivial amounts, such as like things from chocolate, or they happen to have a sip of their parents' soda or something like that, not a big deal. But ultimately, we're not really recommending caffeine for 12 and under. For those who are 13 to 18 years old, okay, the recommendation is actually 100 milligrams or less per day. And that image up there is from Caffeine Informer, and it goes to show you kind of what is 100 milligrams of caffeine. So just over 1 Red Bull, half of a 5-hour energy or a little bit less of that, half of a Monster, a couple of sodas. Okay, a lot of our high school kids aren't drinking half of a Monster or a quarter of a Monster. They're drinking 2 Monsters or 1.5, 3, whatever it may be. All right, so the recommendations for teenagers is actually significantly less. All right, so let's talk about what about alternative strategies. So an interesting strategy. In the last few years, they've developed the strategy of carbohydrate mouth rinsing, meaning that people will swish around a carbohydrate-based beverage, such as a sports drink, in their mouth, and there are transmitter or taste receptors in their mouth that give the sensation of them actually consuming carbohydrates without actually drinking it. Okay, they're just swishing around in their mouth, and they would see a performance benefit because of that. And so then they developed the idea of, what if we just took in a caffeine mouth rinse? Okay, and a group recently, a few years ago, actually produced a positive response to that in sprint cycling. Okay, now a second group did the same study or a similar study and wound up producing no response. So it's something that I think we do need more research on it to find it, but that would be an interesting area. Could we perhaps get to the point where athletes could come into the locker room at halftime, swish around a little bit of a caffeine beverage without having to actually drink it, 5-10 seconds in their mouth, and they get a response? Okay, so that's an interesting area that we need more research on. We know it works for carbohydrates. We're still waiting to find out more information on caffeine itself. Okay, what about beverages? So what things provide caffeine and how much? This is a really good image from Asker Jukendrup, who's a researcher in endurance athletes. He has a website called My Sports Science. There's a very helpful image that just kind of gives you a general idea. So sodas are actually regulated on how much caffeine they can provide. So they're less than 70 milligrams per kilo, or 70 milligrams total. So they're about 30, 40 milligrams or so, versus the Rockstar 2x energy is about 250 milligrams. 5-hour energy is 200, so on and so forth. So you can get a general idea. If your teenage athlete is limited to 100 milligrams per day is the recommendation, look at all those things which are over 100 milligrams, right? And how much of those are they actually consuming? When do they actually consume it? So we talked about this earlier a little bit. 1 hour is before. So if we're going to consume it for performance, 1 hour before is generally what we'll do. However, there are new ideas coming out. Can we wait until later on in exercise? Rather than taking in any caffeine before, would it be more appropriate to take it in late and then you take in much less of it? That's a potential way. There's also the idea of potentially taking in a little bit before and some later on in exercise. So there's not really one specific way to do it. If you're going to consume before, then you would do a little bit more caffeine and you would do it an hour before. If you're going to consume caffeine during exercise, it would be late in exercise and to be a smaller dose. So now we're going to break it down into just different types of sports. So originally where most of the research is caffeine in endurance athletes. And what they would do is see if we go at a certain power or certain pace, so 80% VO2 max is the example I gave up here, how long can you go before you're exhausted, before you can't go any further? Okay, and they would see that caffeine supplementation would improve the duration, so 96 minutes versus 75 minutes in the placebo group. Then they decided, okay, well, how many sports do you actually just go until you can't go any further? Okay, that's not really a sport. That's not really practical. So what if we use time trial performance, which is where you go for a certain distance as fast as you can and see how you perform? And that's where they showed performance improvements with that. So with a smaller dose, 3 milligrams per kilogram, they showed 5.2% improvement in time trial performance in cycling. Okay, we also see decreased perception of effort. So it means that when you're feeling fatigued, when you're feeling tired, when you're feeling like you're working really hard, it takes a little bit less or feels not quite exhausting when you're taking in some caffeine. What about caffeine in team sports? This is a little bit more difficult to follow along with. The problem with caffeine or team sports studies is that how do you really replicate two different games? No one game is going to be exactly the same, so we don't always know, right? But they do the best they can to try and simulate games. Sometimes they'll do it on the bike. Sometimes they'll do it on the field. They'll do a variety of different things. We've done studies in rugby. We've done studies in soccer. More of these studies are typically done in Europe, so they do it in more European-based sports as opposed to what we do here. So not a lot of American football studies in caffeine. Okay, but what we've seen is that passing accuracy can improve. Okay, the amount of distance covered in a game tends to improve when caffeine is supplemented. Okay, we've seen passing and shooting accuracy improve in soccer, okay, especially in a fatigue state. We've seen jumping ability. We've seen more powerful spiking in volleyball as well. Okay, so we have seen in sports performance or in team sports activities that we do see some form of improvement. I definitely think there is a case for caffeine before sports, but I think it's going to be more related to sports where fatigue comes into play, so longer duration sports as opposed to really, really brief activities. Things like where we're covering a lot of ground, such as soccer, rugby, are going to be more, I think, effective overall. But ultimately, we do see some performance benefits with caffeine before team sports performance. Okay, what about resistance training? So there's not a day that I go to the gym where I don't see pre-workout beverages, right? Pre-workout drinks, monsters. The other day I saw a guy drinking a glass mug of coffee on the bench press in between each set. See it all the time. It's always there. Okay. Actually, what's interesting is that most of the research is pretty equivocal. So we see some studies that show benefits, and we see a number of studies that show no benefits. Perhaps the bros and their pre-workout drinks are onto something, because more of the studies that show benefits are actually on bench press and not squats. Okay, so that's a little interesting tidbit. So we tend to see that it's not all that helpful, especially not on 1 rep max. Okay, more so it's going to be helpful on muscular endurance, if at all. And then it's typically more helpful for upper body exercise as opposed to lower body exercise. And I'm not sure why that is, and they don't know why that is. Side effects. What are the potential concerns? For a normal, healthy adult, okay, up to 9 milligrams per kilogram is considered safe and okay. Now, again, everyone has their own tolerances and what's appropriate for them, but that seems to be okay and shouldn't present any significant health risks. They've done studies, like I said earlier, where 13 to 15 milligrams per kilogram raised blood levels of caffeine, but nowhere near to the extent of what's considered lethal. Not saying that I would recommend taking in that amount of caffeine, just saying they have shown that it can be done and is okay. Okay. Excessive doses can lead to issues such as high heart rate, high blood pressure. It can lead to hyperkalemia, respiratory alkalosis, hallucinations, coma, vomiting, nausea, etc. Okay, so this is where the concern for caffeine powder comes into play. Caffeine powder is very, very hard to measure, and we've seen deaths in youth athletes. One, their caffeine levels and what they need are significantly less, but the ability to actually measure it out is very, very difficult to do. And so we see overdoses in that. Okay, in more moderate to high doses, so 6 to 9 milligrams per kilogram, we will see things such as higher blood pressure. We will see anxiety, jitters, GI upset. Okay, we will see insomnia. Oftentimes, a lot of high school athletes are playing sports late at night, or athletes in general are playing sports in the evening. If this is impacting your sleep, is that really helping you all that well? Are you able to recover quite as effectively as you need to? Okay, if your stomach is upset, if you're nauseated, if you're shaking when you're playing a sport, is that really going to help you very much? Most likely no. Again, it is very much dependent on the individual. If I took anywhere near that amount of caffeine, I would be shaking like crazy. So it just depends on you and your tolerance level and the athlete's tolerance level. Okay, what about hydration? This is a common one I'll hear. Caffeine causes dehydration. Caffeine is a diuretic. These are 3 different review articles on that subject. Quotes, doses of caffeine equivalent to the amount of normally found in standard servings of tea, coffee, and carbonated soft drinks appear to have no diuretic action. A later study, there's no evidence to suggest that moderate caffeine intake, less than 456 milligrams, induces chronic dehydration or negatively affects exercise performance, temperature regulation, or circulatory strain. Caffeine ingestion did not lead to excessive fluid loss in healthy adults, and the diuretic effect does not exist with exercise. So, caffeine should not really cause dehydration, should not cause diuretic effects. If someone is not exercising and they are taking a very, very high dose of caffeine, perhaps then we might see increased urine production. Otherwise, if someone's exercising, it's a moderate to low dose, or what we would consider recommended or appropriate levels. Should not cause dehydration, should not cause them to overheat, sweat more than any other athlete, anything like that. Energy drinks. Energy drinks are a tough one. One, they do not fall under the same category as sodas. So sodas are limited as to how much caffeine they can provide. Energy drinks are not. They fall under the subject of, or the category of, a supplement, right? So they can have significantly higher amounts. They can have very generic, misleading terms at times. As long as it's nothing too specific, they can use the same kind of rules that apply to supplements, which are not very much. Okay, they can contain higher amounts, but they also contain other stimulants, so such as guarana and green tea. They're often, while we mentioned earlier, so youth athletes shouldn't be consuming any more than 100 milligrams, yet they are often recommended or marketed toward high school and youth athletes. So that's a concern. They're very persistent in how they market. I was asked a few years ago to write an article. They just wanted me to write a general article on nutrition for athletes. And I was being asked by several different companies, including an energy drink company. And all they asked me was just make sure you touch on caffeine. That's all we're asking. Okay, so I wrote it, touched on caffeine, and they said, well, we want you to write a little bit more positive about caffeine. Okay. Right, so I changed it a little bit, and they were okay with that. And then they said, all right, well, we really want you to touch on B12, because that's really important. So I'm not going to touch on B12. Okay, so then they kept asking and asking and asking. So finally, in order to get them to stop, we talked about B12, very, very important, right? B12 is important because it helps with energy production. However, I went and showed them the numbers of B12 deficient individuals in the United States, which is about 1% of the population, and said they do not need your drink in order to increase their B12 intake. They will be just fine. Only people who are B12 deficient most of the time are going to be vegans or elderly adults, neither of which are probably cramming down energy drinks, right? But nonetheless, persistent on how they were marketing. I have to make sure I tailor it to what they wanted, when originally all I had to do was just touch on caffeine, right? So they really want to market and they really push their product. So we have to be cautious. They are marketing to our kids, our teenagers, and they don't need quite that amount of caffeine. Okay, now it is still appropriate to be fair. And when I started writing that article, I definitely had to kind of review some of the information and material. So there are a lot of studies on energy drinks, okay? And we have shown they are actually beneficial in terms of performance. So this was an article from the International Society of Sports Nutrition, so their position stand on energy drinks. And they said consuming energy drinks 10 to 60 minutes before exercise can improve mental focus, alertness, or anaerobic performance, and or endurance performance. Some of those studies that I mentioned on team sports activities were actually using energy drinks. Okay, so can they promote or can they potentially improve sports performance? Yes. Okay, they can. Okay, do we need high school athletes consuming them? No. Oftentimes they're exceeding the amount that we would recommend for high school athletes. Okay, and they have other things involved in those energy drinks oftentimes, excessive amounts of sugar, etc. Okay, so they can be okay. For the most part, we do have enough. They've been around long enough. We've seen enough people drinking them. There's been very small amounts of health-related issues for them. Okay, oftentimes the health issues do tend to pertain to those who have some sort of condition before that we didn't know about. Okay, but nonetheless, it's not something I tend to recommend. I think it's still too new. I just don't feel all that comfortable with it, so I'm not going to sit there and try and promote it. But I do think we have to be aware of it in terms of sports performance. Okay, practical implications. So caffeine in small amounts or moderate doses of 3 milligrams per kilogram, or what would equate to about 1.5 to 2 cups of coffee for most individuals, can enhance sports performance, especially when consumed 60 minutes prior to exercise. Smaller doses of 1.5 milligrams per kilogram can improve performance when consumed late in exercise or when fatigued. Okay, caffeine mouth rinses are a new and upcoming potential area that needs more research, but could potentially help sports performance. Children and adolescents should be focusing on general nutrition and diet as opposed to supplementing with caffeine. Okay, now you have some of the ins and outs on caffeine and why or how it can be effective, how it can be harmful, right? But ultimately, we still don't want our youth athletes to be consuming them, but it is helpful for you to be aware of all the ins and outs of caffeine. For adults, caffeine can be used for sports performance, but it's something that should be tried out and tested beforehand. You don't want to have that for the first day, you're having 2 cups of coffee right before a race. That's going to go pretty poorly. Okay, usually you want to test that out a couple times in practice. Okay, in summary, small to moderate doses of caffeine in various forms can improve performance in endurance sports, team sports, and potentially strength training. While side effects can occur, they are more common at doses which exceed the levels necessary for performance improvement. Okay, so that is my email address, and that is my Twitter handle, which I already promoted earlier. Please follow me. And if you're interested, like I said, Google search my Twitter handle. There are all sorts of articles on different areas that we just talked about. So if you want to go and dig deeper into that, that would be great, and you're welcome to do that. Any questions related to caffeine?
Versus non-responders.
Okay.
How do I know if I'm a responder or not? Why would I be a responder or non-responder?
Well, one, knowing you don't drink coffee, so you won't be a responder because you don't drink coffee anyways, right? So you're not going to consume it. To me, this would be the matter of testing things out and practicing it and trying it out. So if you seem to see a performance improvement from it, if you feel better, if you feel more energized, then potentially you could have a response to it, right? It may be placebo, it may not. But ultimately, if you feel like it's really helping you, then great. If you try it and test it out and find that I get nervous, my performance suffers, my stomach's upset, then clearly it's not the right thing for you to be doing.
So it's not necessarily if you're naive or not?
As far as new, so it can. So, and we will do some studies where they have people withdraw from caffeine for a few days. Some people where they may get more of an effect of it because they're new to it. But ultimately, you could also be new to it and have performance issues because you're not feeling or you're feeling negative effects because you're not tolerant to caffeine as well. So there's give and take to that. All right, awesome. Thank you all.
Yeah.
Anyway.
Okay. You don't hear me?
I wanted some promotional ideas and some ways to help kind of handle the sports medicine program, promotional wise. And so Chris is the only guy I could think, the only guy I thought of that could do it right.
I appreciate you having me out. I mean, the speakers that are here, I feel very privileged to be speaking for Hermann or for the Sports Medicine Update. I have no financial or non-financial relationships with this conference. And I'm just going to talk about marketing yourself and really marketing your program and athletic trainers as a whole. Nobody's going to do this for you. Okay, if you let people decide, hey, who you are or what your program's all about, without letting them know kind of what you do or who you are, then they're going to make some assumptions that probably aren't going to be very positive. In order to do that, you have to get out of your comfort zone. We're real comfortable as athletic trainers behind the scenes, sitting, taking care of our athletes. We're not real comfortable promoting what we do or what your students do or what you're doing as a whole in your program. And set some goals to be successful. Every situation you get into or every job you take, it might be good, but it's not going to be, it can always be better. So what can you do to improve that? And in marketing yourself, I can help you, maybe show you some ways that you can do that. Now, this is what works for us. It may not work for you, but I'm going to tell you some things that we do that's going to help out. And really, in my mind, professionalism is not about do's and don'ts. It's about respect for yourself and respect for the people around you. If you're acting professional, you're dressing professional, you respect those people that are also doing the same thing. And people in turn are going to respect you. I mean, I'm just a regular athletic trainer like any one of you, and I'm dressed up like this, so maybe you think a little bit highly of me. I don't know. That's my hopes anyway, for at least administration and parents that walk through the doors. They get a first impression. They see, okay, this guy, I can trust this guy. Currently, ATs have an image problem. When I go to Google Images and I search for medical professionals, that first picture on the top is what comes up. You have people dressed real nice. You got maybe a doctor, physical therapist. I like to think the lady in the front is an athletic trainer. But when I search athletic trainers, I get the image, and the top 10 images that pops up is on the bottom. Okay, we're medical professionals, just like the people on the top. So we need to dress the same way. We need to act professionally. When I see an athletic trainer t-shirt and shorts in their own clinic, that in the background is all messed up and disheveled, to me, when somebody walks in, if one of my administrators walks in, and they do on occasion, or my parents walk in, which they do every day, and they see this, they're not going to think very highly of me. They're not going to think of me as a professional. So professional appearance. At work, dress professionally. That doesn't mean you have to wear a suit or a tie, but know what your teachers have to wear at school, or what coaches wear. Not all coaches, I guess. Some of your more professional ones, but I think very minimum some slacks and a polo shirt. Be professionally at work with your colleagues. So at a conference like this, okay, or you go to SWAT or NATA, and you're dressed in shorts and a t-shirt. That's not real respectful to everybody else that's there. That's trying to make this profession better, and we're trying to make ourselves more professional and not look like this AT on the bottom. We need to look like the people on the top. So when you come to a conference, and I know this one says dress comfortably, to me that means slacks and a polo shirt. Okay? If you're wearing shorts and a t-shirt, you're not respecting our profession. You're doing it wrong. You have to have a great attitude. There's a lot of times where you talk to athletes and they make you so mad, and you want to tell everybody what they did. But you gotta act professionally. You have to have a great attitude and see what the problem is, and let's move on from that. Let's not dwell in the past. Okay, here's the problem. Here's the changes we're going to make. Sideline presence. Sometimes when people see you go out onto the court or field, that's the only time. That's the impression they get of you. They don't know you, but all eyes are on you and that athlete that's injured. They see somebody come out there that's not dressed professionally, they're going to think, who's this taking care of my kid? Who is this person that's dressed in shorts and a t-shirt that's trying to take care of my kid? When you come out and you're dressed professionally, they're going to respect you right away. They're going to look at you and say, okay, I can maybe trust this guy to look at my son or daughter. But people are going to get an impression of you because all eyes are on you when you're going out on the court or to the field. Student athletic trainers, they're a direct reflection of you and your program. So if they're dressed unprofessionally, that reflects bad on you too. I have like a 2 strikes rule, and we're going to get rid of you. If you're not dressed in the way that you're required to dress in our program, I'm getting rid of you because you're making me look bad. And I don't want anybody to make me look bad, because if I need something in the future from my administration or from coaches or my principal, I want to be able to get it. I want them to think that we have a real respectable program, and they'll be more willing to give us something, which I'll touch on in a minute. Okay, job classification. I'm not saying one is good versus the other. They're both different, but a lot of us are on teacher salary. I'm on administrative salary, and a few of you might be on administrative salaries too, especially at the high school level. So, and a lot of people love teaching, that's great. And we're trying to get the sports medicine class approved in our district, so we can teach in the classroom, but we do a lot of administrative duties. Just if you're on the teacher salary, make sure you're getting compensated for those extra days you work or that stipend. For the extra days you work or whatever, an extra stipend. We get a stipend on top of our administrative salary just because we do work a lot of extra duties. So policies and procedures. Everybody should have some type of policies and procedures. Okay, some of them are required by law, but you need to have some type of manual that said this is what we're going to do. And I'm not talking about only for athletics for your high school or the athletes in your district. When we make a policy, when we make a heat or lightning policy, that's for our entire district. This is a big administrative duty. We get a lot of people together. This is what we're going to come up with, and this is what's going to be followed. So if lightning's happening and we get our athletes off the field, that means band's got to come off the field. That means that if there's an elementary school and they got kids out on the playground, they got to come inside too. You should also have some rules for your clinic, just for your students, because for us, high school students can be. These are some rules you can follow. If you can't follow these rules, you're not going to be there. So policies and procedures you need to at least keep updated on. I wouldn't say policies and procedures, but recommended standard of care. You may not all be BOC certified. You might be licensed, but that doesn't mean you shouldn't be reading the NATA position statements or official statements that come out. Because if somebody has a problem with what you've done in your clinic, they're going to reference these. This is what's recommended by your professional, by your national organization. How come you're not doing this? And I'm not saying that I agree with everything the NATA comes out with. For example, the secondary school, the athletic training student aid model they had. I don't agree with my students just doing nothing. They can do a lot of things as long as they're in direct supervision with us. I'm not going to let them evaluate an injury or do anything like that, but they can hold a TheraBand, they can tape a wrist, they can tape an ankle. As long as I'm there, they know what they can do. And we're not going to allow them to do anything that's going to harm an athlete. But review those. If you have problems with them or you don't agree with them, make sure you have some type of something a way to back yourself up if you get backed into a corner. And review your policies. This year, we have to review our heat policy. It was made a long time ago, and I think we need to revamp it. Things change over time. A concussion policy we reviewed last year. It had been 5 years since we had first created it, so we said, you know what? We need to take a look at it and maybe make some changes because there's always changes coming down the pipe the way we do things. Your athletic training clinic, it's a medical facility. It should be treated as such. It needs to be kept clean at all times. You never know who's going to walk through the door. Associate superintendents have come by. Our superintendent has been by. School board members come through there. Our principal, our administration, they all come in there. If they come in there and it's clean, they have no problem with me, and I'm well dressed. If they come in there and things are scattered out all over the place, and I'm wearing shorts and a t-shirt, and I'm not saying when you go to a football field you need to dress professionally or at least in slacks. It's hot. It's Texas. I'm going to wear shorts. I'm going to wear a polo shirt, but I'm going to put some shorts on. Well stocked. Make sure you take care of your athletes. And then during athletic activity or when there's athletes there, somebody needs to be in that clinic taking care of those people. Now, we have flex time, so we're not there all the time. Somebody's there, but I'm not there all the time. So who are you? And like I said before, the only way that people are going to know who you are is if you let them know. You got to get out of that comfort zone and go talk to people. You have to assume that nobody knows what you do or who you are or how much you care or how many hours you spend up at work. The only way they're going to know that is if you talk to them and bring that stuff up. And if you can do that, then you can get your foot in the door on a few other things. You know, we spend 60, 70 hours a week at work, during certain times of year. Is there a way we can contract out? Hopefully somebody can help you out. It's about who you know. If somebody tells you differently, they're lying. These are the people that directly affect my program. Some administrators, my athletic director, principal, and the superintendents. These people I have to know. I have to know they're the decision makers. If something's going to happen on our district, as far as me getting a raise or me wanting something or us making changes, these are the decision makers. These are the people that have the money. These are the people I need to know. These people that indirectly affect me, okay? They might not make the big decisions, but they can help me out. I put my communications department on there, probably number one. When you're promoting yourself or your program, there's a communications or a public relations or sports information person and your employer. They already have media contacts and they can get information out to the media to let the community know who you are. Transportation department. That might not help you, but I have a CDL, and so I drive Eagle One. When we're driving to schools, we're rolling in style with Dawson Sports Medicine buses coming. It wasn't easy to get. I got to know my transportation director. I drove summer school bus routes. I waxed the floors at their new transportation building, and ultimately came down to a bet between me and my transportation director whether he was going to paint my bus or not. This used to be a yellow bus, and it was his idea for the chrome rim. So I think he knows who I am. My maintenance department, they can help me out, get something done where I might not have to put in a work order. I can just call them up directly and say, hey, can you help me out? Here's my situation. One situation we had when we first opened is we wanted a separate lock to our office where our medical records were and to our storage room so things didn't walk off. So he said, okay, don't put in a work order. Let me talk to your principal first, because I don't know if they would agree with what you're doing. So he does whatever he's got to do on the backside. I don't know what's happening. And he says, okay, now all you have to do is have a purchase order sent to maintenance to replace your locks. So I had to buy the locks, but he installed them. And now we have locks that only people that can get in our office is us, the principal, and that's about it. The custodians can't access our office or our storage room. Media contacts. You see these people on the sidelines when you're working games. So just go introduce yourself. Say, I'm the athletic trainer. When somebody gets injured on the field, that's me. I'm the guy that goes out there and takes care of them. If somebody's on the radio up in the press box, go talk to them. Give them your card. Say, hey, I'm Chris Shaddock. I take care of the injuries of all these kids, so if the play stops and I'm out there, you might want to mention my name. Here's what I do, by the way. A lot of people don't know what we do. We do a lot of things. We're physical therapists. We're first responders. We're part-time babysitters. Whatever it is, we do a lot of things. It's hard to make people understand exactly what athletic trainers do. Okay, who knows you? I really just use this slide to show a picture of Shaq and I, because Shaq was on our campus this year for a high school slam dunk contest. If I met him again, he definitely wouldn't know who I am. But these people need to know you. My communications or information director, that department, when I walk in the door, they need to recognize me. They might not recognize my name. I know my communications department knows who I am. They know my name. But these departments, they might not know your name, but they need to recognize you and understand exactly what you do. You need to know the different people in your district or within your employer to help you out. But if they don't recognize you and know who you are, then you're not going to usually get what you want. Your community, they need to know who you are. I need those parents to know that when their kid gets to junior high and they're playing sports, that when they sprain their ankle, they don't need to rush off to the emergency room. They can come see us. We can take care of that. They're going to see us for injuries anyway as they stay in our school system. Administrators at your school and at the administration building. You go over there and say hi. Go drink some coffee in the morning up front with your principals. This is where things happen. When they have a little downtime, you can talk to them, let them know exactly what's going on, how many hours you're working, and you might be able to get something done. But people need to recognize who you are. Elected officials, they know who we are. We invite them out to our campus. We have several events where we've had our U.S. congressmen, our state elected officials, our mayor out to help us out, promote something. I just call their office. They'd gladly help as far as coming out there, and they're being seen by the community. And anybody else that can help you and help your position. So find ways to communicate with parents, your community, your coworkers. Like I said before, your communications department, they already have a list of media contacts. They talk to the media on a weekly basis. They submit articles about your employer, about anybody with us, it's our school district. So they're always looking for good stories, good things to put out there, and you can put things out there too. Social media. If your employer allows you to do this, it's a great way to communicate with your community. Here we have a Twitter handle, we have a Instagram account, we have a Facebook account. So we can put important information out, what's going on, here's what we do, this is how we take care of people, whatever it is. Social media is a great way to communicate with people, especially the young population. Website, we have all kinds of information about our program, and then if there's important information, physical forms, or whatever forms they need, we're going to put it on our website, an easy place for parents and the community to find. And professional organizations. You need to know who those people are. You're going to be promoting yourself within your own profession, within your colleagues. You need to know those people, because promoting yourself, by doing that, say you submit your news to Kendall Goldberg. Kendall Goldberg is the athletic trainer that's on the SWATA PR committee. If I need something in the NATA news, I got to contact her. Jeremy Jackson, he's for Jihads. You need to know these people, because you can get your name out there. People recognize who you are, and they understand that you really weren't a professional, conducting yourself in a professional manner. So get involved. I call these this is what I call like a gimmick. This is your way inside to the media. If you can come up with some type of gimmick that the newspapers are willing to pick up, you can put that information, what you're doing, plus add on any additional information about whatever you're passionate about. National Athletic Training Month is a good place to start. Everybody around the country is doing a lot of things to promote our profession. You can do the same. You can promote yourself like we did. This sign on the left here, That's on the roof of our building. I went to our principal and said, I'd like to put a billboard on the roof of the building. We're 4 miles away from Hobby Airport, and the planes land right over our school. She's like, sure, no problem. Just let me know what the message is going to be. So I put, for National Athletic Training Month, each one of these letters is on a sheet of plywood. So it's about 80 feet. Hashtag Safer Sports. That's what we used during National Athletic Training Month. We were promoting anything on our social media accounts. And then our Twitter and Instagram handle at DHS_AT. So when planes flew over, they saw this, and if they could remember it or write it down, then they can go to our stuff later. But hashtag Safer Sports we did on all our social media accounts. I took Twitter for the month of March. Roderick did Instagram, and Gretchen did Facebook. And we try to post something every day. That way, if people are flying over, they can look and see about what athletic trainers are all about. Oops. This gentleman right here, this is Conrad Liu. He just graduated from our school. He's a top 10 graduate from our school. We do an annual hot dog eating contest and free hot dog night during National Athletic Training Month. He ate 9 hot dogs in 3 minutes. He's won the last 2 years. This is this year. Last year, he was about 50 pounds lighter. But it's just a gimmick. Okay, this is what we're doing. We're hosting a community event. People can come out. It's free hot dogs. And we have a hot dog eating contest at halftime of a soccer game. Fundraising for an outside organization, a good one we fundraised for before is Gridiron Heroes. You can say this is what we're raising money for spinal cord injury. And by the way, we take care of athletes, and we take care of spinal cord injury if there's an emergency situation. We're the guys there. Here's what athletic trainers do, and here's what we're all about. Get involved with local or state, national organizations. I learned more about promoting myself or promoting our profession whenever I got on the public relations committee with SWATA and NATA. And about promoting myself outside of just us, athletic trainers, promoting myself to the community and our program. So get involved. Whatever you're passionate about, get involved and make some improvements in our profession. It's not always going to be ideal situation, but you can always make it better. You can't complain about it until you get involved and try to make changes. If you're brave enough, you can podcast like Jeremy Jackson. People know his face. They know who he is and what he does. It's a great promotion tool for him, for his athletic training program, for Pasadena ISD. I think if you want to get your face out there, that's awesome. I applaud what he does. Adopt a Highway, blood drives, anything. Any of these things are gimmicks, is what I call gimmicks. Do it, and then you can submit that to your communications department. Here's what we did. Here's what our students are helping us do in our district. And by the way, here's information I want to get out to the public too. So they're more than willing to run that, especially if it's good that our students are doing things good. Okay, so now you've promoted yourself and your program. You can submit, or you can set realistic goals to improve your work situation. And this is what we've done. We've created a third athletic trainer. We also can still contract out if they don't want us working more than 3 nights a week. We don't come in until 10 o'clock half the time because we're on flex time. So it's a pretty good situation. It wasn't always that way. We had to kind of work to get that way. So if you set some goals, if you want an additional athletic trainer, you need more storage space, a bigger budget, salary, whatever it is, if you work on promoting yourself and your program and knowing those people around you that can make those decisions, you're going to have a better chance of achieving those goals. But if you're sitting around in shorts and you're at shorts at work and your principal comes in a suit and sees you, hey, they're not going to think of you in a professional manner. But if you're always promoting your employer in a positive way, they're going to be more than willing to help you out. So talking to the media, become a source of medical information. You see those guys every day, every time you have a game. Talk to them, strike up a conversation. Hey, say if you have any questions on any type of injury, give me a call. I'll help you out. I'm not going to go over any specifics on the athlete or violate any FERPA or HIPAA laws, but I will be a source for you if you need me to be. Answer their questions. They're going to throw you some softballs, answer those questions, and then get your own point across. Hey, yes, we do take care of injuries. And by the way, did you know that only 45% of athletic trainers in the nation have access to an athletic trainer. So whatever it is, whatever you're passionate about, get your own message across too. Whenever we submit stuff to our communications department or to the media, I always pretty much do a press release. I put in there, this is exactly what I want in there about what we've done. Here's some additional information, and then submit that with pictures. And our communications department is good about, they'll proof it for me and they'll make some changes if they see fit, and then they'll submit that. The media, sometimes, I would say less than half the time, if you give it to them directly, they're going to change it and it's going to be wrong. Probably more than half the time. And that's okay. I mean, as long as your information is getting out there. Sometimes it's incorrect. Sometimes they're going to use the tag, if they're looking for a headline, it might say trainer. I don't get upset about that. I just want them in the article to use athletic trainer. A lot of times it's about space, especially in the headline. Submit articles regarding health and wellness to run in the paper. I've done this. And a good way to start, an easy way to do that, is to read the NATA position statements. If it's something that's relevant to maybe your athletes or your community, just add a quote in there. Add a quote somewhere about whatever it is. If it's low back pain, low back injury, I'll always, if it's something that we're submitting, I need to put a quote in. I usually put a quote in for Roderick or Gretchen and let them know, here's what I put, here's what you said in the media. Because if you make it, if you localize it, if there's a quote from somebody from Massachusetts, nobody cares in Pearland, Texas. But if there's a quote from Roderick, he's the athletic trainer at Dawson High School in Pearland, Texas, then they're more willing to put that in a paper. Here's somebody that's in our community that's talking about low back pain, and it looks like it's related to, and it is related to, the National Athletic Trainers Association, because it's coming from official statement. Always add quotes. They like that. The media likes that. So in summary, you have to get out of your comfort zone. You got to get out of that little cave in the athletic training room and go meet people. Go introduce yourself to the media, to your administrators. Get to know them. Those people are going to help you out. Always have a professional appearance. Keep your athletic training room professionally, like a medical facility it is. And keep up with professional standards. So read those NATA position statements or SWAT or whatever, whoever, TSATA, whoever comes out with something, you need to be up to date on what's going on. Things change. If I didn't read those position statements on concussion or keep up with that, we might still be doing things. I might still be holding an athlete out for 15 minutes and then sending them back to play. You have to keep up to date. You have to evolve and change. You can't be scared. You got to get out of that cave, get out of that comfort zone. Identify people that can help you and achieve your goals. That's your administration or whoever it is. My goal is to get a blue bus. I need to target that transportation department. Market your program. Marketing yourself. I'm marketing my program. When I'm marketing my program in my school district, and they love that. Your school district loves the fact that, hey, this is what you're doing. In fact, tonight we're being recognized at our school board meeting because we won the National Athletic Training PR contest for National Athletic Training Month. So when we win that, I submit that to our communications department. By the way, here's what we've done. I didn't expect to get recognized, but they want us all there. They want to give us, I can't think of what the name of the award is, Pearland Golden Pear Award. Golden Pear Award. Become a resource for your media and the communications department. If they have questions about injuries or illnesses or policies, have them call you. No, tell them that your door's always open, your phone's always open. Call me if you need any type of resource. Okay, that's it. That's our U.S. Congressman Pete Olson right there, judging our hot dog eating contest. Okay, and one of my students in the back in a hot dog costume.
Hello. Oh, this is on. This is awkward. Obviously, everybody knows that. Well, I guess we'll go ahead and get started for those people who miss or leaving for the potty break. That's, I guess, their loss. Anyway, I have the honor of introducing our last speaker for the program today. Actually, now that I think about it, I had to introduce the one who was last yesterday, so it's probably more of an indictment on myself than anything. But anyway, with that said, I'll keep my remarks short and brief. Speaking of short and briefs, our next speaker is coming up here, and I'm sure he's going to have you at the edge of your seat. Hopefully it's because it's intriguing and funny and interesting, not necessarily because you're ready to leave. So with that said, I'm going to turn it over to our friend and our colleague, for the most part, Mr. Mike Vara.
Hello. God damn. Hello, there it is. All right. Thank you, everybody. Thanks for coming. Okay, now let's try it. You know how this song goes. Come on, you know it. Okay, I want to explain this cartoon where I got it. There's several of these Larson cartoons in my talk. Years ago, I used to teach. That ought to tell you enough right there. But so I'm in class, and there's one of our football players sitting in the back, and you know he's not being disrespectful. He's just not paying attention. So I kind of wandered down there. His name was Larry Mitchell, wonderful young man, and he looks up and he, you know, I said, "What are you doing?" So he closes this book and he puts it under his desk. I said, "No, man, let me have it." So I get it and I throw it on my desk, you know, got to look all pissed off and that kind of thing. So class ends and he walks up and he goes, "Can I have my book?" I said, "No, I'll give it to you later." Well, I started going through it and it was the, you know, Gary Larson's greatest cartoons. And this was one in there and I loved it. I loved it because if you look at it, look, he's putting on the shoes. And what are these jokers over here doing? What are they doing? They're like, "Hey, something's getting ready to happen." And I love it because he's like, "Okay, I'm going to tie these things up," and then the fun starts. So anyway, that's the purpose I did this one. I love the cartoon and it means a lot. But Larry didn't graduate, so that's okay. Sports medicine on the run. It's something I used to tell my student athletic trainers. I said, you know, nothing's very formal in what we do. You know, we see an injury, we're gonna look at it, and then we'll move on. You know, I didn't have a book, and you know, kudos to Chris. His talk was great. That really is how you do a program. He's got one of the top programs in this area, without a doubt. I'm sorry he uses a short bus, but that's besides the point. But my kids were a little different. Because they were a reflection of me. You know, don't take it serious. Let's just, you know, pick up the towel, pick up the bottle, clean the training room, let's get going. And so
when I ride around in the truck from school to school, is Brad in here? Anyway, when I ride around, all these rumblings are in my head, and this is how this presentation came about. It wasn't anything that I sat down in front of the computer and started tinkering with, but it's things that I've thought of over the last months. And then last year I did a talk. It was called The Lighter Side of Athletic Training, and it, it was things like, you wear your sports medicine gear to bed, and you're trying to make love to your wife, and here's the Thundering Herd shirt on, and so those kind of things. But and we kind of pushed it more about the kids. I asked people to submit pictures of their student athletic trainers, so that's kind of what I focused on. Well, this year I wanted to do it on us, on physical therapists, athletic trainers. We have a lot in common. I really don't have a problem with anybody in our profession. We're all pushing for the same thing. So sports medicine on the run is what I wanted. That's what I want to talk to you about. I don't have anybody that cares about me, and I don't care about anybody else, so it's all good. I believe that there are a lot of components to a sports medicine program, and the underlying there is successful. Nobody is successful on their own. If you say that, you're a freaking liar. I'll tell you right now. When you look at where you get, and go back to Chris's talk for just a second, you push your program, you talk about what you want to do, your goals, you get in front of people, you talk in front of the school board, you wear big boy pants, all that kind of stuff. I agree with that, but when you're successful, however you gauge successful, you do it because other people have allowed you, they've pushed you, they've given you the resources to do that. So, when we talk about a sports medicine program, we're going to talk about the things, the matrix, the things that make it up. But I truly believe that you can't be successful on your own. I don't care what it is, in the movies, athletics, divorce lawyers, whatever you're looking at, you can't do it on your own. So I did want to give you a quick definition of sports medicine on the run. For me, it was a style of care and treatment that's given, and you just don't roll out a towel and say, here, wipe the blood off your face and I'll see you in 10 minutes. You guys are more than that. And you're a good example. You're here at the end, your butt's tired, you're ready to go home. You got our free gift. You could have walked out, and I'm not bitter that I didn't get one, but that's okay. Please, when you leave with your free freaking gift, don't think about me at all. Changes constantly as needed, and you've got to. We're gonna. That's a point down the road here. Is that you need to change. That's why you're here. You want to pick up bits of nuggets of things that you can use. Dr. Teunis. I'm sitting up here looking. I'm thinking, what's that in the wrist? And I'm trying to act all intelligent, like, yes, I knew what that was. Hell, I can't even spell handmade, but that's okay. Willingness to accept new ways and ideas, that's got to be, you've got to have an open mind. Let's face it, what we do, either in the clinic, in the training room, you're dealing with people, young people in most of our cases, they don't know up from down, and they come in and they will tell you things that they won't tell anybody else. And if you think about it, and I can use my example, taping kids before a football game, they come in, I didn't care what they were wearing. I mean, they couldn't come in all crazy looking, but I didn't care if they wore headphones or they sang or cut themselves. I didn't care what they did. As long as I knew they were going to give their best effort. I used to tell them, you come in on game day, we'll tape your eyeballs if I thought it'd make you play better. But during the week, they didn't get anything. But for us, sorry, did I say that out loud? But you gotta accept things. You gotta look at. So sometimes not everybody's the same. Not all the kids are the same. So you gotta refocus and try to help those folks. Efforts and attitude. Effort is what you give. Let's face it. You give what you get. You give a great effort, you expect a great effort in return. Attitude. We could do a whole talk on attitude. Think about your colleagues that didn't come to this thing, that stayed home. They're home asleep, and I get it. I know you're tired. You've had a long year, but hey, there's stuff to learn all the time. I'm 31 years old, and well, I'm actually 34, but
There's stuff all the time, but your attitude, you know, and you in my travels, when I get out of my Mo Hermann truck and I'm walking with my Mo Hermann shirt and I'm walking in, I've got a pin to give you and, you know, things like that. And you walk in and how do I get a job like yours? I said, well, you got to be bitter for so many years before they can hire you, I guess. But, you know, attitude really, you could spend weeks on talking about attitude and how it affects other people. Think about it. When you wake up sick and you go to work sick, the people around you, it changes. It's like you walk in with, you know, egg on your face or something. People will see you differently, and people understand attitude. You can smell a bad attitude coming, and we'll talk about it in a minute. One of the biggest definition of sports medicine on the run is great management, not good or okay or more better or more gooder. It's great management of the sports medicine matrix. And you're thinking, wow, matrix, he used a big word. This is what I consider to be the sports medicine matrix. It's the athlete / the patient, depending whether obviously you're an athletic trainer or a therapist, the physician, the coach, and I didn't spell it with a K out of honor of Coach Gillis, parent, spouse. Man, we're going to talk about those people. We're going to rip them here in a minute. And then the athletic trainer, the physical therapist, and teamwork. I love this picture, and I hope you guys can see it. Can you see what that lion on the ground is doing? He's got the other two jokers are sitting up there. Look at the lady in the car. I just love it. She's like, oh, look, Bert, look what they're doing. And this guy down here is, they're thinking dinner. So that's how you work. That's a good example. That's what I love about teamwork. Okay, some things that you hear, we're talking about the athlete and the patient. When people are injured or they're post-surgical, you know, you might hear some things like, you know, how long before I can return to full activity? You know, they're going to give you that crappy answer. Well, my team needs me. No, they don't. No, they don't. You know, I don't care. You know, you look at somebody like Johnny Manziel, bless his heart. I hope that guy, whatever, figures it out or whatever. But, you know, all the donations to A&M went up after he won the Heisman. And they're like, man, here we go. We're going to forget we're playing the SEC, forget that LSU's in there with us and Alabama and all this stuff. And my team needs me. I would tell them, okay, that's what I would tell the kids. Well, they need me. I'm like, look, this is 9th grade B team football. Nobody cares. My scholarship. I'm thinking your scholarship. I didn't know the Merchants Marine gave out scholarships. So. And you know, in that sack, because here's a kid, you know, weighs 125 pounds, one good eye, can't run, and they're worried about, you know, they're going to go to Harvard or somewhere. I've seen this in the clinic. People think, well, I've got to get back to my job. I'm like, look, dude, you work at Walmart. What's the big deal? You know, I don't mean that disparagingly. You know, Walmart's a great place. I'm sure I don't shop there, but I'm sure it's a good place. My job, you know, why are you in such a hurry to get back? You know, you're broke down. Let's get you well, that kind of thing. But hey, it is what it is. This is my favorite one. My dad had this injury and he walked to school. I'm like, so you were poor and didn't have a car, or, you know, you were out of the 2-mile bus zone or something, or whatever the case is. Something else you hear is, why do I have to do this? If you're a physical therapist and you're in the clinic, you work one-on-one, right? Are there any physical therapists in here? You work one-on-one, correct, with people? I mean, they walk in and you pull out their charts and, okay, ice bag, $300. You know, correct? I'm sorry, no disrespect, I guarantee it. But how much effort is given to trying to make that person that comes in, you know, why do I have to do this? And then you say, well, you know, because range of motion is really important to get, you know, whatever. We go back to the 9th grade B team football guy. You're like, here's your ice, sit in the hall, I'll get to you when I can. Why do I have to do this? I tell you, because it's boring. Well, we always had music in the training room, always. Of course, it was always on 99.1 Sunny.
But I mean, nah, too bad. It was my station, my radio, so we're gonna listen to what I wanted. So it hurts, duh. That was always my answer. I'm sorry, you know. Well, it hurts when I do that. I said, well, yeah. And you walk off. You know, of course, you pat him. You give him that "I love you" pat, and you walk off. So slow and deliberate. I'm like, man. Now remember, we're gonna go 1, 2, 3, 4. You got it? Yes, sir. Okay, that's good. That's good. Thanks. My dad had this injury. Yeah, you know. You'll hear it from the athlete or the patient. Well, you're not the doctor. That's not what the doctor said. You're not a doctor. And I'm like, and I'm thinking in the back of my mind, well, your mom, blah, 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 you know. You know, yes, I'm not a doctor. Yes, you're correct. And you're not a student athlete either, so we're even. For those who don't know, this is Dr. Bing. He is, Dr. Mark Bing is a legend, and Katie is a good guy. He was one of our team physicians when I was at Seven Lakes. A wonderful man. So I would never tell him that. I guarantee it. For those of you that know him, he doesn't wear socks. Don't know why. He didn't. So he'd kick you with his bare damn foot. So, and your answer is no. I work for a living. So that's been my answer to when someone says you're not a doctor, at least in the G-rated sense, anyway. So. Okay, if 3 sets are good, 15 or better, you know, I'm like, well, no, that's not the point, because our next little doodad here is bless that overachiever. You know, they think, well, I'm going to do 15 sets in the morning, 15 sets during the athletic period or during my clinical time, then I'll do 15 at night. And you're like, well, you're going to have a hell of a hip, you know, but that's not going to do much good for your knees. So, and then again, my dad had this injury, and yeah. Okay. Who in this room does not know who that is? Thank you. I used to hear it all the time. Oh, dog. And I'm like, dog, like D-O-G or D-A-W-G exclamation point. My man, what is it he says? Oh, somebody help me. I'm sorry, I'm drawing a blank right now. For shizzle, thank you, yes. I'm thinking, I couldn't put that in here because I couldn't spell it. So I thought, when I first started typing it, it looked bad. I thought, man, no. So, but dog, kids are great. And again, the folks in the clinics, bless your heart. You know, I would think that the people that are coming to PT clinics are more civilized than a high school athlete is. But man, the kids would say the craziest things. It goes back to what I was telling you before. You know, and you hear it under their breath, like, oh, dog. I'm like, what? I remember the first time I actually got called dog to my face. And I must have turned like 6 colors because everybody stopped breathing in the room. And I was like, dog. So I walked away and said something about his family. So it was even. How strong relationships you have with your physician? The next component of the sports matrix. Sports medicine matrix is your physician, and a very important one, obviously. Mutual trust in each other's skills. You know, I don't know anything about surgery. I know that when the kids came back from all the team doctors I had, we were ready to go. I would tell the parents, you comfort the parents. Even the places that I go as an outreach athletic trainer, I say, hey, here's a list of doctors that we use. I trust any one of them. You know, I know what they can do. Although my first year as an athletic trainer, I was in San Antonio for 5 years before I moved out here. We had a team physician. We call him Scoping Joe, because everything got scoped. I mean, he had his office, his waiting room was about this big. And there were people that would wait outside to get in to see this guy. Of course, I was young, impressionable, had more hair and all that kind of stuff. And I thought, you know what? This can't be the way you do it. So needless to say, after my second year, we didn't use him anymore. Access, what kind of access do you have with your physician? As in the clinic, I see the PTs, they've got the orders from the doctor. They know the doctor. Sometimes, like in a couple of our clinics, they can walk down the hall, although I don't know if you can still do that anymore because of insurance, and they build a wall and all this kind of stuff. But when it was Rich and Bone and Joint Clinic, we used to be able to walk in and out, and there was no problem. To me, that was how you did it. It was a very successful menu. So access to your doctors are real important. Protocols, do you have standing protocols in the clinic? You know, I know you got to have a script, or you got to be careful with insurance issues, things like that. But, you know, in the training room, kid comes in and the note says, please rehab. And you're like, okay, because you know what your physician wants. But if it's somebody else and they say rehab, you're looking at the paper, you're like, well, rehab what? How do I do it? What do you want? So you call the doctor, then you get your butt in trouble because now you're calling the doctor. You know, you're not a doctor, so why are you calling me, kind of thing. Where do you stand with the office manager and the staff? I'd like to hear some of your horror stories someday. I can give you 2 physicians that no longer practice in this area that were our team doctors, and both of those practices were run by their wife. And the first one, I didn't realize the devil wore makeup. I really didn't. Man, I'd walk in there and she goes, do you know how to fill out a claim form? And I'm like, lady, wow. I said, yes, ma'am. You need to put, and I'm the whole time thinking I'm gonna just pimp slap this lady. You know, and then you get past her, and the rest of the office is wonderful. They're great. You know, they were super. Hey, no problem. We'll make you a copy. You know, we'll send it in. Blah blah blah. And I'm like, great. And then the other physician we had, bless his heart, he went back to Tennessee, I guess because he wanted to see what Arkansas. Get it? Tennis. It's okay. It didn't work. I did try it on the cat yesterday. It didn't work either. So, but she was worse. I think she actually thought I worked for her, because she would call me up and say, okay, you know, are you bringing this kid in and back before lawyers and stuff? I said, yeah, I'm gonna bring him in. We're gonna come in. We're gonna get practice started. Then I'm gonna take him in. Well, you have to be here by 4 o'clock. And I look at the clock. It's like 3:58:30. And I said, well, we're not gonna make it. Well, we're gonna stay on schedule. Like, okay, needless to say, she gained weight and became obese, and that was that. So, how many of you know what the Stark Law is? Stark Law? Yeah, deals with physicians and gifts and things like that. And I don't know, we don't abide by it, but those of you that present, give your stuff to your team physician: a shirt, a cap, a jacket, a sideline pass, shoes, socks, unless you're Dr. Bean, you know, things like that. You know, it's all part of that bonding, that what you do with your physician. I realize in a clinic it's harder because there's more restrictions on you, whereas in the training room it's maybe a little more loosey-goosey. Plus, what you do in a training room is a lot different in terms of injury recognition right there on the sideline, as opposed to being in the clinic. So the relationship, maybe that bottom one is a little different, but yeah, the Stark Law is a real deal. So they remind me of it. They tell me about it constantly. So what type of relationships with coaches? Again, I've been blessed in my career with the coaches that I have used, I've been associated with. Wonderful people, male and female. Good. There's only been a handful in my 36 years of being an athletic trainer that there's only been a handful that I wish lightning would hit. You know, for the most part, they were great people. You know, I never had a problem like, well, are you sure? And they whisper like they don't want anybody here. Are you sure they're out? And I'm like, yes. And I don't think they ever got it, but that's how it is. Is it a bromance? Are you in love? Are y'all hug? You know, y'all fist bump? And, you know, what is it you do? Those of you that are in an area where you have to work with like Pop Warner football, Little League football, you know, we've got some contracts with some area youth league football. Man, those guys, they're something else. There is no bromance there, I guarantee it. They're just crazy. And it's weird because I talked once at a clinic for some of the youth football coaches, and 3 or 4 of them were former athletes of mine. And they're gracious young men. It's good to see them growing up. They've got kids, they're responsible, but they're crazy. They forgot what they did when they were in high school. They forgot how the coaches yelled at them, made them feel, and they're doing the same thing. I'm like, fellas, what are you doing? Anyway, love, hate. I heard some stories out here. I'm out here in the hall, working registration, and people say that if you're nervous in front of a group, imagine people in what? What are you supposed to imagine people in? Their underwear, yes. So as you're walking in, I'm envisioning every one of you in your underwear. And it was frightening because I saw a lot of tramp stamps. And there were even some on some of the women. So mutual respect, that's tough. I think that's CERN, go back to Chris's talk here just a few minutes ago. And it's hard. Respect is hard. You're not given, you earn respect. How you treat people, how you treat a coach when they're walking. I don't care if they're a freshman football coach. I don't care if it's a youth football league coach. It's a respect thing. You look down on people, and one day you're going to be down there with them. So it's I have a license and you don't thing. I've heard that before. That's your final answer. Well, I'm licensed, you're not. I'm like, that may not be the best thing to say. I know you're frustrated. I know you're mad. I mean, I know. But to throw that one out, to a coach, that to me, that's kind of crappy. But anyway, yes, sure, okay, right away, I'll call a doctor. So instead of mutual respect, you have no spine. So you're afraid of that overbearing coach. And I worked with one for about 2.5 months. And he was the south end of a northbound mule. I guarantee it. He was horrible. He was horrible. And I pray every day that the OIL finally catch up to him. But you gotta respect your license. You gotta respect your obligations to the kids, especially in a high school setting. Well, I'm gonna focus on high schools right now, but you got an obligation to those kids. I don't care what happens. I don't care what they say in the coach's office. When you walk in and they get quiet, that's their problem. So we talk about, if you gotta dig your heels in and protect your turf and fight your battle, then so be it. Sorry, it's after 5. I loved it when Chris said they can't work more than 3 nights a week. Wow. Chris is so cute. I just love his program, man. He's wonderful. They got 3 athletic trainers at their school, and they've got electricity and all that. It's just wonderful. We just got running water my last year there, so it all worked out. But you're willing to work, and I'll show you something else here in a minute. But the 5 o'clock thing really always gets me. I like 5 o'clock. Damn, we're just starting, your second defensive session by then. So, okay. You have to read this. You've got to read this. Parents are nuts. They really are. I remember when we would have morning treatments at 6:45, and I'd come around the corner and I had a back door into my office, and I'd come all chipper because you're excited. You want to come back. You left at midnight the night before, and you're coming back, and I look down the hall, and there's 3 parents standing there with their coffee, and they got their ID from work, and they're just ready to go, and they wave, and I just, what's up, and then I wait till 6:45, and they're looking in the window of the door, and I'm waving, and they're waving, and so, anyway, and you folks in the clinic, bless your heart. You got Maul waiting on Paul. He's had a hip replacement, and she's sitting there clutching her bag, and she's mad because they had to park by the oak tree and walk in, and but we have free coffee at our clinic, so I guess they can get over it. And I understand that. I understand they're crazy. They want their baby, the meal ticket. I love that one. I actually had a parent tell me that once. So I'm like, wow. I guess the cheese effort was out of there too. But broke down Gimper, that is a medical term. There is a code for it. But you know, they ask you the same thing. Well, when is this going to end? When will they get back to normal? You're like, well, I don't know. You can't say, well, approximately 6 weeks and 4 days. You know, I don't know. I mean, we're going to get them back as soon as we can. But that's what parents are. Parents are crazy. And if you're a parent and you do this, you come up here and we're going to front you out right now. I guarantee. I don't understand it. Why? Well, anyway, you're a parent. I get it. My daughter played volleyball for 2 years. She was horrible. Horrible. Still is. And I used to, after their games, you know, they would kill people. And she'd be on the bench and they'd put her in and she'd do her bad thing for a couple of, you know, sets and then take her out. And, you know, I love her. She is my world. I guarantee it. I wouldn't do anything. I would do anything for my baby. But God, she was horrible. And I never said anything. She said, Daddy, what'd you think? I said, oh, that was great effort. That was maximum effort. Your scholarship. You know, I walked to the school in snow and blah, blah, blah. Anyway, there you are. So. Okay, how do you interact with them? Again, with a parent or a spouse. Is it friendly? It better be, because I've had that before. They've sat down on your desk. Well, I pay your salary. I'm like, God damn. Yeah, you do. Yes, you do. But I take care of your kid. So there you are. It all works out. Cordial, like it's friendly. Okay, hello, Mrs. Johnson. How are you? Cordial is, hello, Miss Johnson. How are you? You know, and then this is a good one here. Combative. And it says, again, I love it because the guy's not too concerned about that his friend's dead, just that they misspelled the word surrender. So there you are. Little or no interaction, to me, that's dangerous. If you have little or no interaction with parents, you're just setting yourself up for failure. Right or wrong, they're still the parent. You know, they have some say over what happens to that child. And they can make your life miserable or they can really make it great. Again, going back to what Chris said, you know, you put your face out there, you put your name out there, you shake hands with the parents, you give them a card, you recommend they go see a certain physician for a certain injury, and then you're right. You know, when you think, you know, well, I don't know if they've got a fracture, but you know what, let's splint it, let's go in and get an x-ray, see what, and then you're right, and they call you, oh, you're wonderful. And I said, yes, you were right. Well, you know, it was good. I had an educated guess, and you know, your diagnosis was correct. Well, we don't diagnose, you know, we just take a freaking good guess. And here we go. I love this one here. I'm going to use my little pointer. Okay. Look in the tree. Who's awake? Who's awake in the tree? And I love it because here you are. Now you've wakened this idiot over here. I love his antenna and everything, but he's got cameras. So he's done this before. Would this describe you? Is this what you want people to think of you, as a slumbering giant? And then when they finally ask you something, you're going to tear them up. I love this guy. Larson is great. Anyway, I don't even know if he's still alive or not, but that's here. Who knows what these little things are called? Lemmings. Very good. And what do lemmings do? I don't know. They go to the sea. That's all I ever knew. But this guy right here, they're all doing the same thing, but here's this guy right here, sports medicine on the run. He's a little different from everybody else. So what type are you? What type of athletic trainer or therapist are you? Are you the caffeine craze, get it done yesterday type? Those are the ones that we can't stand. Okay, don't sugarcoat it. Don't say yes, there's my friend. No, the guy's a loser. You need to get rid of him. Here's my favorite, the office chair sitter. That's why they put rollers on chairs, so you can scoot and say, 2 more sets. You scoot back, scoot over, another set. And I'm like, hey man, don't drop your taco while you're moving. So I know more than you. That's the second most dangerous person. You know, if there's 2 of you and you're trying to bounce ideas off each other, or if you're in a clinic and you see someone doing something wrong, do you walk over and say, hey, you need to keep your legs straight, or you need to take your shoes off on the table, or, you know, don't do that. Well, let's avoid that one. That's just a recipe for violence. Let's see. I should have gone to med school, but I have asthma. Yes. And we hear that all the time. Well, I was going to go to medical school. And I'm like, so what stopped you? You know, was it your grades? Was it money? Or no, it was asthma? Okay. Is it really necessary to ask? Yes. I'm going to ask you, why am I doing this? How long is it going to take? Yeah, that's a person that, you know, they answer your question, they'll look at you, and they'll go back in their office. And I unfortunately worked with a person like that once. How do you respond when asked questions? This is great. This kind of goes back to what I did last year. I came up with some original quotes. Down goes Frazier. Is that what you tell somebody asks you a question? That's what you say and walk off? That would be great. Meet my little friend. I can't do it in the proper accent. I'm sorry. I refuse to do that. ET phone home. That's something else you ask. Is that the answer you give? This is my favorite. Bueller. 30 years old this month. Ferris Bueller. And I bet I've seen it, 100 times? It's great. I love it. Anyway, so there you are. This is my favorite, Bond. Yeah, I knew you'd get out of you. I know some of y'all have Netflix and that kind of stuff. Go ahead and make my day. This one was a little corny because it seems kind of passive aggressive, but man, we'll let it go. I see dead people. I'd like you to say that on the way out of a halftime in the locker room. Well, how's it going? I see dead people, and just walk off. So. This is for the gentle of heart. I'm sorry. I just put in there. I figured after that dead people one, we need to be kind of. Anybody remember what that line's from? What movie that's from? Yeah, Jerry Maguire. It ended stupid. There was a stupid ending. Hey kid, throw the ball, and he looks all spaz and he throws it, and I guess his dad walked to school in the snow or something. I love this one. Anybody know what this is from? It's a commercial, the Geico commercial. The guy's fighting in kung fu, and and his mom's turning the page. Are you taking a Zumba class? And I love that. Anyway. So you don't watch TV? Oh. And here's my favorite. You've got to be quiet. I'm going to see if this works. You've got to be quiet. Nope, didn't work. Hello? Nope, didn't work. No, this is.
You tell them I'm coming, and hell's coming with me, you hear? Hell's coming with me!
Sorry.
You tell them I'm...
Sorry, folks, it's like my marriage didn't work. Sorry.
You tell them I'm coming, and hell's coming with me, you hear? Hell's coming with me!
Now that's what you say when you come out of the dressing room. That's what you... We'll muzzle through this here. Some famous people you could see working in sports medicine. Spock. I like, what's wrong, Johnny? Well, it's Vulcan mind meld and find out. That way you're not going to lie and tell me that you're not concussed. Could you see him walking into your staff meeting? It's great. I mean, I love this guy. He's going to sue you. If you blink wrong, he's going to sue you. And so you walk in right away, you're ready to, I'm going to sue you because you wore shoes in the training room or you farted on the treatment table or something. That's my girl. That is my girl. T Swizzle. I'm just not going to say anything. I'm just going to watch it for just a second and then, man, anyway. I thought about a whole lot of people, and I wanted to put the Duke in there. Some of you are probably too young to even know who this is. John Wayne, the greatest American that ever lived, or so I've been told. But I could picture him walking out on the field, the kid laying down there. You better get up, boy, and just walk off. Which I've heard before. So many stories. That could be a whole talk in itself on what people say on an injury assessment on the field. Man, that's the Duke. Bless his heart. This idiot. The only reason and I'm not political, so I'm sorry if this is your favorite guy or so you're going to vote for him. I don't care. It doesn't matter to me. I'm not going to vote at all. But could you see him with a cap? Not the one that says keep America great or make America, but with one of your coach's caps, running out in the field and go get an injury and it flies off and then his hair's everywhere. And they'd have to get EMS just for his hair, I guess. So, my boy right here, concussed you are. So my boy right here. Hey, what are we going to do? I'll be back. That's teamwork. I hope you can read this. Say, look what they're doing. You get it? These guys are walking. The other guys are flying. Get it? Teamwork, flying, lead by example. Hello? Okay. Damn Larry and his book. Working well with others sets a positive tone. You have to. You're in close, confined quarters. Just be positive. My God, there's enough negativity in this world. Look what happened this past weekend. Work well with others. It really does. It will make a difference in what you're doing. Monday through Friday, you're with your colleagues, your coworkers, sometimes Saturdays, sometimes Sundays. It makes for a long, long time. Sometimes the days all run together. You know what day it is. So teamwork is tough. 8 to 5 or longer. I realize you're thinking, you're probably laughing, God, who works 8 to 5? But it's a long day regardless of what you do. Especially if you're with someone on your team, especially with someone on your team who you would wish would go away. I mean, that's the nicest thing I can say. You're together during lunch hours and meetings. When I became part of Mamal Hermann, I realized what meetings were for, and it's so I could have coffee. I swear to God, but lunch hour, sometimes you have to meet. I know some of the clinics do this. They'll meet during their lunch hour. So you're trying to eat and figure out, what's going on. So yeah, teamwork's a tough thing. Picking up the slack for a coworker. Now, I didn't mean to put the word slack like someone slacking off, but someone comes in and their child's sick. They got to go pick them up from school. And you say, go ahead, we got this. That's what we're talking about, teamwork, something like that. Maybe you don't think that's an example of teamwork, but I do. It happens. You're not worried about what's going to happen because someone will always pick you up. I think that's an important thing to remember. Sharing as needed. I don't need to know that you've had back acne for 2 years. You don't need to share everything, but sharing, sometimes you just want to sit down and somebody says, hey man, what's wrong? Oh, my dog's limping or something. And then you get into discussion about better care of animals worldwide or something like that. So how flexible are you? You know what? You got to be flexible. I was talking about change, and I've got something here in a minute, but if you're not flexible, you're going to be in for a long life. I guarantee it. It's going to be tough. And you guys are flexible. Look, you're still here. Listen to my idiot self. So I love this quote. Progress is impossible without change. And those who cannot change their minds cannot change anything. I don't know who George Bernard Shaw is, but I love his quote. And I saw it in a muscle car magazine. I'm getting the oil change, and I look and I read the quote, and I thought, wow, such a random place to put, because I'd seen it before. I'd seen the quote before. And I said it was such a random place to put in. They were talking about a 66 Mustang. They were going to fix it up, and I don't remember just. So I wrote down the quote, and here it is, and you can have it, and there you are. Okay, and we do it well, so make your program great. How you do that, be it clinical, be it athletic training, let's work on doing it. This is my quote, so if you want to write it down, go ahead. I'll give you the copyright rights. Success occurs because many share the workload, not the excuse. I can't stand excuses. I can't stand drama. Just do it. And if you have to shut your mouth to do it, then do it. But in the end, everybody's successful because you do it all together. don't sweat the small things. I know that's a corny thing people said before, but I think it's true. You know, you're mad because that kid's pants were droopy. I remember that was a big thing with us. You know, kids' pants were sagging, you know, and you saw their SpongeBob SquarePants underwear. And I was like, hey, I don't care. The guy's in class. He's doing his work. I don't care. To me, it was a big, small thing, but others thought it was a big deal. Keep your career in a proper perspective. Again, going about what Chris had just said, the things that he mentioned about, you know, being positive, getting your program out there, doing the things. I agree with that. Keep it in perspective. You know, if you spend more time at work than you do at home, then you better make sure when you get at home, that's quality time. That's all I'm going to say about that. If you love your job, you know, it's your career, and every day you go and you're happy to be there, then that's great. You're going to last in it a long time. I think I was blessed in that regard, that I love what I do. It's a lot of fun. I've been very lucky. I've been blessed, the people I work with, the things that have occurred to me as a professional. Hey, home-wise, it was a little tough. But I guarantee it, up until then, it was full blowers with me. I'd go home after Sunday treatments. All I wanted to do was sleep. But hey, we're going to go eat. We're going to go to the movies. Let's go. Let me change my Thundering Hurt t-shirt and let's go. Athletes' parents have good and bad days. I don't know if this picture is real. I don't know. I mean, I'd hate to think that you spent billions of dollars with a bridge and it comes out like this. But we all have our good and bad days. I guarantee it. Everybody does. You know, so don't judge somebody because they've had one bad day and you're gonna send them to purgatory for the rest of their life. That's not fair. Okay, kids, I'm gonna back off and we're getting ready to rock and roll here.
We got it together, didn't we?